A very good afternoon, esteemed. A very good afternoon, esteemed principal, heads of respective departments, faculties, and our dearest students.
On behalf of the Scientific Academic Research Society and Asian Medical Students Association, we take immense honor in welcoming all of you once again to BLD's first undergraduate case presentation competition, Medical Mysteries.
All of us have organized this event with the main intention of sensitizing you all to the culture of paper presentations and case report presentations and creating confident speakers and presenters.
Yesterday was a testament to this vision as we witnessed 13 young minds with one-of-a-kind cases, striking presentations, and the knowledge and confidence to back it up.
We are beyond thrilled to see what the rest 13 other contestants have in hold for us today as we begin the day 2 of Medical Mysteries.
We would like to introduce our esteemed panel of judges. Dr. M.M. Patil, sir, HOD Department of Pediatrics and Dean Research and Development. Dr. Manjunath Kotnawar, sir, HOD Department of Surgery. Dr. R.N. Karadi, sir, HOD Department of ENT. Dr. Rajshri, ma'am, Professor, Department of OBG. Dr. S.M. Biradar, sir, Professor, Department of Medicine. Dr. Sandeep Nayak, sir, Associate Professor, Department of Orthopedics. And Dr. Chandrika Dodehal, ma'am, Associate Professor, Department of Community Medicine.
All the presenters and judges, please note the rules for the presentations. Each speaker can speak for a maximum of 7 minutes. One bell will be rung at minute 6 and 2 bells will be rung at minute 7. This will be followed by a 3-minute discussion with a panel of judges. One bell will be rung at the end of minute 3. There will be 1 minute break between each presentation for the judges' convenience of scoring.
We wish all the contestants the very best for their presentations. And if the judges are ready, we'd like to begin with our first contestant for the day, a third-year MBBS student, Shri.
Good afternoon to one and all present here. Myself, Shri, a third-year MBBS student. Today, I'll be going to present a case study of olfactory neuroblastoma from the Department of Otorhinolaryngology, that is ENT. Coming on to the case, a 21-year-old female presented to ENT OPD with the following chief complaints. Left-sided nasal obstruction since 2 months, frontal headache. History of presenting illness, left-sided nasal obstruction since 2 months, which was not relieved on medication, gradually progressed to right side since 6 days. Altered smell since 1 month, which progressed to loss of smell since 15 days, and it was also associated with the change of voice since a month. Frontal headache was present, which was insidious in onset, mild, dull aching, gradually progressive in nature, which relieved temporarily with medication. And it was also associated with the running nose, snoring, and mouth breathing. There was no history of nasal bleeding, facial pain, ear discharge, ringing sensations in the ear, visual disturbances, bone pain, difficulty in breathing or swallowing, throat pain, voice change, cough, fever, or weight loss. Coming to the past history and family history, nothing was significant. Her menstrual history and personal history, everything was normal, and she had no drug allergies. Coming on to the general physical examination, her nutritional status, heart rate, blood pressure, everything was normal. And on systemic examination, all the systems which were examined were normal. Coming to the otorhinolaryngologic examination, on examination of nose, the external appearance of the nose, osteocartilaginous framework, root, dorsum, tip, ala, everything was normal. And on tip elevation, the columella, vestibule, both bilaterally were normal. And on anterior rhinoscopy, the nasal cavity showed bilateral nasal discharge with nasal mass. Nasal mucosa was bilaterally normal, and the septum showed deviation towards the right, and the turbinate was normal. And in the left nasal cavity, a pale whitish mass was seen in the nasal cavity, filling the entire nasal cavity, extending till the floor, which could be probed all around except superiorly, and it was not bleeding when touched. Test for smell perception was done with clove and coffee, and it was absent bilaterally. Paranasal sinus examination, left ethmoid sinus tenderness was present, and on visual examination, bilateral ocular movements were present, and on neck examination, there were no palpable lymph nodes. On examination of ear, oral cavity, and oropharynx, everything was normal. So based on the history and examination, we came to a provisional diagnosis as it is a sinonasal polyposis. Now, we had few differential diagnoses in the mind to confirm the diagnosis. These were the differentials: antrocornal polyp, inverted papilloma, olfactory neuroblastoma, fungal allergic sinusitis, that is fungal ball, and sinonasal carcinoma. So the management, we first did investigations. The routine investigations were normal. Radiological investigations were done. Biopsy was done, followed which the treatment was given accordingly. This is the CT scan of paranasal sinus. As you can see, a soft tissue density was noted in the left maxillary sinus and the left nasal cavity and nasopharynx, which was pushing the septum towards the opposite side with widening of the osteometal complex, and there was contrast uptake noted. The mass was causing erosion of the left superior, middle, and inferior turbinates and the cribriform plate. Mild S-shaped DNS was also noted. This is the MRI with contrast of paranasal sinus. Posteriorly, you can see the mass extending into the nasopharynx through the left posterior choana, causing complete obstruction of the bilateral posterior choana. There was no obvious intraorbital extension of the mass noted. Coming to the histopathologic findings, the report was grade 2 according to Himes classification, that is olfactory neuroblastoma. So finally, we came to a diagnosis that it was olfactory neuroblastoma belonging to CADI stage 3 and grade 2 according to Himes classification. So this treatment was done. Transnasal endoscopic excision followed by reconstruction with Hadad flap was performed. Symptomatic improvement was seen during the course of the hospital, and the patient received 33 cycles of adjuvant radiotherapy. Here you can see the picture of the excised tumor mass. This is the post-operative progress. The post-operative progress, you can see the sphenoid sinus, which is patent, that shows that there was complete resection. And 3 months post-op also endoscopy was done. There also no evidence of mass was there. So complete resection was achieved. MRI was also done. Here also you can see the clear nasal cavity. So clinical and radiological evaluation showed no evidence of recurrence. Coming to the discussion, esthesia neuroblastoma, also known as olfactory neuroblastoma, is a rare malignant neoplasm of the sinonasal tract originating from the olfactory neuroepithelium present in the upper one-third of the nasal cavity. Bimodal peaks of incidence at 10 to 25 years and 50 to 70 years is noted, with equal predominance in both male and female. It is a locally aggressive neoplasm and it metastasizes both via hematogenous and lymphatic routes, and it accounts for 2 to 6% of the nasal cavity tumors. That means it is rare, although seems to have increased incidences in the last decade. Now, this is a brief etiology of the disease. On the left side, you can see the normal development as to what has to actually happen in the body. On the right side is the neuroblastoma formation. Here you can see the dark blue color is the neural plate and the green color one is the neural tube. So in between the neural plate and the neural tube present are the neural crest cells. So the function of these neural crest cells is to migrate, that is epithelial to mesenchymal transition occurs, and they are destined to differentiate into particular organs, like they form chromaffin cells of adrenal medulla, or they can form cervical sympathetic ganglion, etc. And all this process is under the regulatory control of the MYC gene. And this MYC gene is in turn under the control of FOX2P gene. So if there is any mutation in the FOX2P gene, there is overexpression of the MYC gene, which leads to neuroblastoma formation. Concluding my topic, olfactory neuroblastoma is a rare and a malignant tumor, and it can exhibit wide range of behaviors, indolent to highly aggressive, and diagnosis is challenging because it is due to its rarity and similarity to other tumors. Early detection and treatment are crucial for improved outcomes. Multidisciplinary approach involving ENT, neurosurgery, radiation oncology is required, and it has a high recurrence rate, often due to incomplete resection. That is why complete resection is necessary. All these unique characters make olfactory neuroblastoma a fascinating yet a complex tumor to diagnose and treat. These were my references. Thank you.
Congratulations for your nice presentation.
Thanks.
Can you tell me the incidence of this olfactory neuroblastoma?
Sir, incidence actually it is bimodal peaks of incidence can be seen like 10 to 25 years and 40 to 70 years, and it is a rare tumor. Actually, it accounts for 2 to 6% of the nasal cavity
To
tumors.
label it as a rare disease, first you have to tell the incidence. Okay.
Yes.
What is the common site for neuroblastoma in the body?
Sir, neuroblastoma it can
Or
happen in the adrenal gland and cervical sympathetic ganglion.
In which age group it is more common?
Sir, neuroblastoma actually it is common in children.
Very good.
Sir. Yes, sir.
In this patient, what was the age of this patient?
So this patient was a young adult, like 21 years old she was. So
And did they make the pre-operative diagnosis of olfactory neuroblastoma in this patient, or it was a post-operative HPI report?
no, sir, it was pre-operative. HPA biopsy was done, then it was diagnosed it as olfactory neuroblastoma. Then
it was a post-operative diagnosis, isn't it?
So pre-operative diagnosis was done before operation.
Then they had done biopsy.
Biopsy was done because to differentiate between.
So they had done a biopsy for diagnostic purpose. Later on, they went ahead with permanent this one.
They
final
excise the mass.
resection of the mass.
Yes.
Does the patient need any follow-up?
Yes, sir. Radiotherapy, adjuvant radiotherapy was given after which
surgery followed by adjuvant treatment in the form of radiotherapy. I'm asking follow-up after complete treatment. Surveillance of the patient, what you call it as. Even though you have given complete treatment, it is known for recurrence, isn't it?
Yes, sir. So recurrence is when it is incompletely resected. See here it was completely resected.
If there is incomplete resection, that is not called as recurrence. That is called as residual, isn't it? So when you are given complete treatment, then only comes the question of recurrence. So you have to follow up the patient. Even though you have done complete resection, even though you have given complete treatment in the form of adjuvant radiotherapy, you have to do follow up of the patient, isn't it? Maybe like initially once in 3 months, once in 6 months, later once in a year, once in 5 years, like that. Okay, good.
Thanks.
Normally, neuroblastoma, they tend to metastasize early, particularly in pediatric age. What are the sites of secondaries in the neuroblastomas? If you find out a case of neuroblastoma, you tend to see these sites for the secondaries.
Yes, sir. So normally we check in the abdomen, like it can present with abdominal mass or something like that, and it can go in the neck, like neck mass can be there, or lungs also it can metastasize too, so that can lead to breathing difficulty. So,
The common site of metastasis scalp, just
yes,
your
sir.
hand over the scalp, just see the secondaries and orbit. Okay. Is it radial sensitive?
So, yes, sir.
Moderate sensitive. Very common. Moderate sensitive. Some patients do respond depending on the differentiation.
Thank you, Andy.
Thank you. That was slot number 14. Coming up, slot number 15, a third year student, Varshita.
What happens when a seemingly common infection like acute separated otitis media turns into a silent threat capable of paralyzing the face? Good afternoon, everyone. I am Vashita, and today I'll be presenting a case of acute separative otitis media with facial nerve palsy, which was post-operatively diagnosed as granulomatous tubercular type. Tubercular otitis media is a rare cause of middle ear infection, 0.05 to 0.9% of cases of COM. With classical triad of symptoms like painless ear discharge, facial nerve paralysis, and multiple perforations of the tympanic membrane. Here we are going to see a atypical presentation of tubercular otitis media in an adult male, mimicking symptoms of ASOM with facial nerve palsy. This is a case of a 53-year-old male laborer by occupation hailing from Vijayapura. His chief complaints were discharge from left ear for 2.5 months, left ear pain for 10 days, right side deviation of angle of mouth for 3 days. HOPI. The patient was apparently all right 2.5 months back when he started having left ear discharge, which was insidious in onset, intermediate in nature, scanty in quantity, mucopurulent, yellowish, white in color, non-foul smelling, and non-blood stained. There were no aggravating or relieving factors. Patient also complains of left ear pain, which was sudden in onset, gradually progressive in nature, throbbing type radiating to the left side of the face, which was temporarily relieved on taking analgesics. Patient complains of deviation of angle of mouth to the right side, drooling of saliva, and unable to hold food in the mouth for the past 3 days. He has no history of reduced hearing, ringing sensation, swelling around the ear, trauma, ear bleed, giddiness, or vomiting. There is no history of fever with neck rigidity, headache, visual effects, nasal obstruction, facial pain, hawking sensation, throat pain, swallowing difficulty, breathing difficulty, or voice change. Past history, there was no similar history in the past. He is not a known case of diabetes, hypertension, tuberculosis, chronic heart disease, CVA, and seizures. There was no history of blood transfusion or surgery. Personal history, sleep was unaltered, appetite was vegetarian, bowel and bladder was normal and denies any addiction. Family history, there is no significant. General physical examination, the patient aged 53 years old is conscious, cooperative, and well-oriented time, place, and person. Pallor, ictus, cyanosis, clubbing, and general lymphadenopathy and edema are all absent. On ENT examination, on ear, on the right ear, preauricular area, pinna, postauricular area were normal. External auditory canal was clear. Tragal sign and fistula test was negative. Tympanic membrane, it was a pearly white tympanic membrane with cone of light present in the anterior inferior quadrant with normal malleolar folds in anterior and posterior. On the left ear, there is a defective ear. Preauricular area, pinna, and postauricular area were normal. External auditory canal was clear. Tragal and the fistula test was negative. The tympanic membrane was congested with a small central perforation seen in the posterior inferior quadrant with pulsatile discharge. Master tenderness was absent. On tuning fork test, left ear, it was negative on testing with 256 Hertz. And Weber's test, it was lateralization to the defective ear, that is the left ear. Absolute bone conduction test was same as the examiner. So this leads to an inference of left side mild conductive hearing loss. On facial nerve examination, the right ear, it was normal and intact, whereas in left ear, there was House-Brackman type 2 facial nerve palsy. Nose examination, oral cavity examination, oropharynx, and neck examination were all within normal limits. Systemic examination, CNS, higher mental function was normal. On cranial nerve examination, left-sided facial nerve palsy was noted. Rest cranial nerves were normal and intact. CVS, S1, S2, and RS and PA were all normal. This is a case of 53-year-old male presented with acute ear discharge since 2.5 months. In his left ear pain since 10 days, and left side facial weakness since 3 days. There was no significant past or family history. On examination, left side tympanic membrane showed congestion, small central perforation in the posterior inferior quadrant. Tuning fork was mild CHL, and facial nerve examination shows element facial nerve palsy. So this might be a case of left acute separative otitis media with facial nerve palsy. These are my differential diagnosis: tubercular otitis media, acute exacerbation of the CSOA, malignant otitis externa, Bell's palsy, and Ramsay-Hunt syndrome. Investigations of HRCT was done, where there was advanced bone growth, there was advanced bone growth of the petrous part of the temporal bone, and PTA revealed mild CHL. Surgery modified radical mastectomy with type 3 tympanoplasty under local anesthesia and sedation was done. Unhealthy hypertrophied tissue from mastoid antrum was sent for histopathological examination, and CB-NAT was done. Preoperatively, he was unable to close his eyes, and there was right side deviation of angle of mouth, and blowing of the cheek was reduced. Postoperatively, on the day 1, the angle of deviation of the mouth was improved. There was complete closure of the eyes, and the blowing of the mouth was improved. Post-op day 3, histopath confirmation of granulomatous otitis media was made. Anti-tubercular drugs were studied immediately after notifying NTEP officer. ASOM is a bacterial infection, mainly Streptococcus pneumonia and H. influenza of the middle ear with pus accumulation. Facial nerve palsy in ASOM occurs due to proximity of the facial nerve in the middle ear. The inflammation may cause pressure on the facial nerve, leading to paralysis. TOM, tuberculous otitis media, is a chronic granulomatous form of otitis media. Typical presentation is painless otorrhea, multiple perforation, facial nerve palsy. Complications like mastoiditis, labyrinthitis, meningitis may occur. Management by ADT. TOM, in this case, was even in the absence of history of TB, was there, and there is mainly 2 spread hematogenous and primary TB of the ear. Though tubercular otitis media is a rare case, we should be vigilant for atypical presentation, as in this case, and also include this disease in the differential diagnosis and considering it will lead to an accurate treatment and prevention of serious complications.
Very good presentation. What message would you like to give through this case?
Sir, tubercular otitis media, though it is a rare disease, so we need to keep it under a number of differential diagnoses, since it has similar complaints as ASOM and CSOM. Like in tubercular otitis media, there are 3 clinical triad of there was 3 multiple perforation, facial nerve paralysis, and painless ear discharge.
In this case, there was no multiple perforation.
There was no multiple perforation, but there was facial nerve paralysis that was seen, and that is.
What is the cause of facial nerve paralysis?
Sir, here because the infection was in the middle ear, and the facial nerve is in the petrous part, which is towards like petrous part of the temporal bone, which is closer to the middle ear. Facial nerve passes in the middle ear. So any disease in the middle ear affects the facial nerve. Therefore, we were able to see facial nerve palsy here.
In this case, there is no mention regarding chest X-ray. Whether effort was made to look for the
chest X-ray was taken and it was normal. He has no.
You did not mention it. In a tuberculosis, if you get tuberculosis at some side, you should look for other sites as well.
Yes, sir.
Okay, because treatment depends upon the other sites as well.
Yes, sir.
Through this, any patients, particularly in a pediatric case, any patient with ear discharge, at least get one AFP done.
Yes,
along with gram stain. Because there may not be any classical features of tuberculosis media, as you say, multiple perforation, painless otorrhea, and particularly in pediatric age group, you are not able to examine the
tympanic membrane.
so
Yes, sir.
easily.
Yes, sir.
Thank you.
Thank
and one more thing, you said the resolution of facial paralysis.
Sorry, sir.
Facial paralysis improve recovery you said.
Yes, sir.
Facial paralysis.
Huh.
When did this recovery happened?
It was on post-op day 1.
Even before starting ATT?
It.
After how many days of starting ATT?
Sir, ATT was done after post-op, after day 3, sir.
So recovery took place before starting ATT.
Yes, sir. There was a decent amount of improvements, so not entirely improved. There was no.
Okay. That means if it improves immediately, means there is just a neuropraxia. It's just a neuropraxia. Okay.
3 to 4 weeks, then the nerve would have been discontinuous. So it would take more time and AKT drugs have to be started.
Yes, sir. ATT was
some early stage. What are the other causes for granulomatous temporal bone disease? Any other differential diagnosis for granulomatous disease of the middle ear?
Granulomatous.
Because caseating the granuloma, so they were not confirmed by AFP staining of tissue as tubercular. Many times granular. So sometimes any other differential diagnosis you should keep in a granulomatous middle ear disease or temporal bone disease.
We since it was facial nerve palsy, we very much to it.
Patienopathy can occur in any granulocytosis, like histiocytosis, X, Handschiller, Christian's disease. So there are other granulomatosis you have to keep in mind, because many times HPR do not give tubercular bacillus positivity.
Varshita,
Yes.
it was a good presentation.
Yes, sir.
Can you tell us how tubercle bacilli is spread to this middle ear? Route of spread.
Sir, hematogenous spread is one of the causes, can lead to middle ear infection, or it might be primary TB infection that can happen directly to the ear, which is a very rare case, sir.
Most of the time it will be from upper aerodigestive tract, isn't it?
Yes, sir.
Maybe from the tonsils itself. If hepatogenous spread is there, patient would have developed multiple foci of tuberculosis, like miliary tuberculosis. And your treatment always, in any case of tuberculosis, treatment should end with medical line of treatment. That is a complete course of ADT.
Yes,
that
sir.
you are not mentioned, isn't it? Otherwise, it was good presentation.
Thank you, sir.
Next, we have slot number 16, third year student Vitusha.
Good afternoon, everyone. I'm Vitusha, and today I'll be talking about Larsen syndrome in a fetus with recurrent maternal miscarriages. Larsen syndrome is a rare congenital osteochondrodysplasia that affects about 1 in 100,000 newborns. It is characterized by the presence of cervical spine anomalies, anterior dislocation of the knee, dislocation of elbow joint and the hip joint, equinovarus deformities of the feet, long fingers with shortened metacarpals and spatulated distal phalanges, and dysmorphic facies with frontal bossing, hypotelerism, and a depressed nasal bridge. Larsen syndrome can either be autosomal dominant or autosomal recessive. The classic form of Larsen syndrome is usually autosomal dominant, caused due to the mutations in the FLNB or the filamin B gene. Filamin B gene is an important protein for the development of skeleton before birth. It is present in the cell membrane of chondrocytes, which is essential for the proliferation, differentiation, and ossification of the chondrocytes. Mutations in the carbohydrate sulfotransferase 3 gene have been identified as the causative factor for the autosomal recessive cases, which is quite rare. Apart from Larsen syndrome, FLNB gene mutations have also been recognized in atalo-osteogenesis type 3, boomerang dysplasia, and spondylocarpotarsal syndrome. Diagnosis of Larsen syndrome is usually made based on the family history with typical radiographic and clinical features. There's, however, no commercially available diagnostic tests due to a variety of heterozygosities in the FLNB gene. Diagnosis of Larsen syndrome is usually made in the postnatal period. Prenatal diagnosis has been reported in a few instances, but is highly challenging. This report pertains to an autopsy case of Larsen syndrome in a 17-week-old fetus. A 21-year-old female presented to the clinic at 17 weeks of gestation with an obstetric score of Gravida 3, Para 2, and no live children. The patient's first pregnancy was at 18 years of age, but it was a molar pregnancy. The second pregnancy was at 20 years of age, but the fetus revealed increased nuchal translucency. Anomalies scan was overall not very abnormal, but there was rocker bottom feet recognized in the anomaly scan. The couple were informed of the possibility of chromosomal anomalies, but the fetus was not terminated. Ultrasound at 35 weeks revealed breech position of the fetus, mild oligohydroamnios, and uteroplacental insufficiency on Doppler test. The fetus was stillborn with suspected Larsen syndrome, but there was no autopsy performed. The proband is a 17-week-old fetus of a 21-year-old female, which was conceived naturally to a second-degree consanguineous couple. Antenatal checkups were performed regularly, and there was no history of administration of any teratogenic substances. There were no known comorbid conditions in the mother. At 13 weeks, non-invasive prenatal screening was performed that revealed low risk for any chromosomal aberrations or genetic mutations. At 17 weeks, fetal anomaly scan revealed multiple skeletal deformities, which was suggestive of Larsen syndrome. This reveals prefrontal edema, mid-phase hypoplasia, and an upturned nasal tip. This reveals bilateral clubfoot, congenital talus equinovarus, and mild hyperextension of the knee, suggestive of grade 1 genu recurvatum. Congenital genu recurvatum is the pathological hyperextension of the knee joint. It can be positional or malformative, but malformative was observed in this case, which is mostly associated with Larsen syndrome or arthrogryposis multiplex congenita. Once diagnosis of Larsen syndrome was made, due to the absence of oligohydramnios, postural CGR was ruled out. There were no chromosomal aberrations that were revealed on NIPS testing, and main differential diagnosis of Larsen syndrome is otopalatodigital syndrome type 1, which does not have large joint dislocation, so that was also ruled out. There are multiple other syndromes associated with congenital dislocation of large joints, but these were ruled out due to the absence of muscle wasting phenomena, joint stiffness, and contractures, and typical facies was indicative of the Larsen syndrome. The fetus was therapeutically aborted at 17 weeks of pregnancy due to a history of multiple miscarriages and the presence of similar complaints in the previous fetus. Examination of the fetus, after the medical termination of the pregnancy, there was a full body X-ray performed of the fetus, which revealed congenital metatarsal varus, congenital dysplasia of the humerus, segmentation anomalies of the vertebrae with hypoplasia of the vertebral bodies. Histopathological examination and internal appearance was normal, but the external appearance was significant in the diagnosis of Larsen syndrome, which revealed frontal bossing, flattened midface, hypotelorism, bilateral low set ears, bilateral long spatulated fingers, bilateral elbows and hips flexed, bilateral hyperextended knees, bilateral clubfoot, rocker bottom feet, congenital dysplasia of the humerus. Autopsy report of the fetus confirmed the diagnosis of Larsen syndrome. However, the genetic studies of both the parents turned out to be normal, and the DNA analysis of the fetal cord blood and fetal skin tissue was inconclusive. In the present case, there was a history of 2 previous miscarriages, first one being a molar pregnancy and second one being a stillbirth with similar complaints as to the third pregnancy. Prenatal scan of the third fetus suggested suspicion of Larsen syndrome, and autopsy case also concluded the fetus to be a patient of Larsen syndrome. However, genetic diagnosis is a crucial part in the diagnostic sequence of Larsen syndrome. In this case, genetic studies of both the parents turned out to be normal. DNA analysis also was inconclusive. Though genetic basis is not established in the current fetus, presence of typical skeletal deformities, multiple maternal miscarriages, and history of similar deformities in the previous fetus are strongly suggestive of the Larsen syndrome. Prenatal diagnosis of Larsen syndrome is challenging due to the limited presence of diagnostic modalities, as there is a wide range of heterozygosities in the gene. However, the diagnosis is done postnatally, and children with Larsen syndrome do live into adulthood and can lead normal lives with mild medical intervention. Intelligence of such individuals is completely unaffected. Treatment is usually done by conventional management of the clubfoot, open reduction for joint dislocations, and through spinal fusion for any cervical deformities. Larsen syndrome being a rare genetic entity, its prenatal diagnosis being difficult, the case contributes in reinforcing the need for heightened awareness and vigilance in managing high-risk pregnancies. These are my references. Thank you, sir.
That was a very nice presentation. What was the genetic testing of the parents done? What type of genetic?
Karyotyping, ma'am.
Karyotyping.
Yes, ma'am.
So in this case, do you expect any abnormal karyotyping of the parents?
Yes, ma'am, because it's generally inherited to autosomal dominant trait.
Hmm.
So generally, we expect any heterozygosities in the chromosome 3p arm, but there was no karyotype.
What type of karyotype? Because many a place only the numbers are seen
Yes, ma'am.
and not the specific genes.
Yes,
Unless
ma'am.
you ask for it, you won't get it. And my second question would be, how early can you diagnose this? Now,
Ma'am.
fetal cord blood and other things you have done after the abortion.
Correct.
So many a times you won't get a good result.
Yes, ma'am.
So even though you know you're going to abort this one, you want to prove it in view of the next pregnancy, what test can you do?
Ma'am, in general, Larsen syndrome is difficult to be caught through any kinds of genetic testing, such as NIPS or amniocentesis or any of these testing. The most important, crucial prenatal finding would be from the anomaly scan, ma'am, because most of the skeletal deformities will indicate
How
Larsen
early do you
syndrome.
want to do this anomaly scan?
Uh,
Is there any role in the 11 to 14-week scan or
No.
early anomaly scan?
No, ma'am. In general, the NT scan does not reveal anything, and the skeletal deformities cannot be recognized prior to the normal anomaly scan, ma'am.
Since both the parents are normal
Yes.
and you said it's autosomal dominant condition, how do you explain this in this baby?
So there are very few autosomal recessive cases caused by carbohydrate sulfotransferase 3 gene mutation, and also there are few other genetic mutations in the skeletal development proteins which have still not been recognized, and the diagnostic modalities are also very limited, sir. So it's hard to
Another explanation, there can be de novo mutations can occur in that
yes,
case.
spontaneous,
Spontaneous.
sporadic cases. Yes, sir.
Coming up next is slot number 17, a third year student, Tahir.
Good afternoon, everyone. My name is Tahir. I'm going to present the case on slipped capital femoral epiphysis. What is SCFE? During a period of rapid growth in adolescence, weakening of upper femoral physis and shearing stress due to excessive body weight may cause the femoral capital epiphysis to displace from its normal position relative to the femoral neck. This is known as slipped capital femoral epiphysis. The incidence of SCFE varies according to race, sex, and geographic location, and is estimated to be approximately 2 per 100,000 population. It usually occurs at the age of puberty between 12 to 14 years and is more common in boys. Patient history. Here, a 16-year-old male patient from Vijayapura. He comes with a chief complaint of difficulty in walking since 15 days. The patient had a history of fall 2 months back from a stationary bike, due to which he injured his right hip and complained of pain, which was sudden in onset, gradually progressive, radiating to the right knee and of dull aching type. It aggravated on walking and relieved on rest. Patient visited a local medical practitioner, took medication for 1 day, after which the pain subsided and he went on doing his daily activities. Patient started complaining of pain again 2 weeks back, which was associated with limping. Patient had difficulty in squatting and sitting cross-legged. He had no history of weight loss, loss of appetite, or evening rise of temperature. He had no history of blood dyscrasias, no history of multiple joint pain, and morning stiffness. Patient had no significant past history. Personal history was normal. General physical examination. Here is a young male who is moderately built and nourished, is conscious and cooperative, and well-oriented to time, place, and person. He has a BMI of 22.3 kg per meter square. Vitals were normal. Pallor, icterus, cyanosis, clubbing, lymphadenopathy, and edema were not present. Prismatic examination, no abnormal findings. Patient presented with Trendelenburg gait, attitude. Patient is lying in supine position with head centrally placed and bilateral hip and knee in extension. The right lower limb appears to be shorter than the left limb. The right patella and medial malleolus appear to be at a higher level than the left, with bilateral feet in gravity-assisted plantar flexion. Local examination of the right hip. Patient is examined in standing and supine position from front, side, and back. He has no swelling of Willis and Scarpa's triangle, no discharging sinuses, scars, no visible muscle wasting, no visible exaggerated lumbar lordosis, no scoliotic deformity. The gluteal folds were at the same level, and the dimples of Venus were also at the same level. Palpation, no local rise of temperature. Tenderness is present over the right hip anterior joint line. No tenderness over greater trochanter. The bilateral femoral pulses are comparable. All inspection findings confirmed by palpation. Movements. The examination of the movements, the active flexion of the right hip was up to 0 to 20 degrees, and the movement was painful, and the passive movement was up to 0 to 40 degrees, which was painful as well. The extension of the right hip was up to 10 degrees, abduction up to 20 degrees, adduction up to 20 degrees. Internal rotation was not possible, and external rotation was up to 45 degrees. Measurement. There is a 2 centimeters of apparent and true shortening, which was confirmed by the Bryan's triangle. Here you can see there's a 2 centimeter shortening. In the mid thigh and mid calf circumference, there were no discrepancies, which confirms that there was no muscle wasting. The special tests done were active stretch leg raise test, which was up to 20 degrees, Trendelenburg test, which was positive. Telescopy test could not be elicited because the hip could not be completely flexed, and Thomas test was negative. The provisional diagnosis is right hip slip capital femoral epiphysis. The investigations done for this case were X-ray of pelvis in both hips, anterior posterior view was done, and frog leg lateral view was done. This is the AP view of the both the hips. Over here, you can see the left leg, the epiphysis, which is the epiphysis. This is the neck, and this is the diaphysis. Over here, the epiphysis is in the horizontal plane, whereas on the right affected limb, the epiphysis is in a slight vertical plane. A line drawn here along the upper border of the neck of femur is known as Klein's line, and the line normally intersects the epiphysis. So you can see a part coming above the line over here. Whereas on the affected limb, the line passes without intersecting the epiphysis. So this is known as Stretowen's sign, which is positive and is indicative of SEFE. This is the frog leg lateral view. Over here on the left limb, you can see that the lower border of the neck of femur is continuous without any breakage with the epiphysis. Whereas on the right limb, you can see that a part of the epiphysis is slipped or dislocated posteriorly, and you can see a shadow over here. The treatment given to this patient was of surgical treatment was given of internal fixation with cannulated cancellous screws or CC screws. Under all accepting precautions, spinal anesthesia was given. Patient was put on a traction table. Position was confirmed under fluoroscopy, C-arm fluoroscopy. Incision was taken on the lateral aspect of the proximal femur, and guide wires were inserted. Fully threaded 4 mm CC screws with washers were inserted up to the capital femoral epiphysis, and placement was confirmed under fluoroscopy. The outcome of the surgery was that the patient was free of pain over the hip area, and the right limb is not weight-bearing till further evaluation. This is the post-op X-ray. You can see the 2 4 mm screws passing through the neck of femur till the epiphysis to prevent further displacement of the epiphysis. SEFE is one of the most commonly missed diagnoses. It is associated with obesity, growth spurts, and endocrine abnormalities. While SEFE occurs with minimal or no trauma, a history of trauma should not automatically rule out SEFE, and thorough examination should be done. So this case, one of the unique things about this case was that it presented with a history of trauma. The variable symptoms of presentation of symptoms. Usually SEFE presents with progressive and continuous symptoms, but in this case, the symptoms first occurred, then there was a symptomless period, and the symptoms reappeared. Unilateral hip involvement. Usually SEFE presents with bilateral hip involvement, but in this case, unilateral hip involvement and the right hip is involved, whereas in many studies, it is shown that the left hip is more commonly involved. These are my references. Thank you.
In the negative history, you asked history of multiple joint pains.
Yes, sir.
What possibility kept in mind while asking this question?
Juvenile onset arthritis, sir. Juvenile arthritis.
What
That
juvenile
can-
arthritis? Juvenile idiopathic arthritis?
Yes, sir. Idiopathic arthritis. Usually,
Or rheumatic fever presenting as arthritis?
no, sir. The juvenile arthritis, because there was no multiple joint pain or no stiffness in the limbs. So that excludes juvenile arthritis and this.
Usually in a juvenile rheumatoid arthritis, a juvenile idiopathic arthritis, a rheumatic fever, involvement of hip is very, very, very rare.
Okay, so no, the small joints are usually involved, but it can spread to the larger joints as well, sir.
And another causes where multiple joint involved along with hip will be viral fever with arthritis.
Yes, sir.
Tuberculous arthritis doesn't involve hip. Rheumatic
Yes, sir.
fever doesn't involve hip. Rheumatoid arthritis doesn't involve hip. One thing.
Okay, sir.
Another thing is how to differentiate into Patil disease.
So in Perthes disease, it's a majority of times it's a bilateral hip involvement is present in Perthes disease, and it's no sir bilateral because the blood.
The case was
Yes sir, yes sir.
it was rare, na? It
Yes,
was
sir.
bilaterally for this.
Okay sir.
Usually there is unilateral involvement.
So in
One of
Perthes,
your friends presented, it was bilateral. It was one of the rare.
okay sir.
That was a rare and rare.
So, but Perthes disease affects children of a younger age group between 5 to 10 years, whereas this affects like a puberty age group between 12 to 14 years. And Perthes disease usually affected due to the blood supply of the head or femur is affected, whereas the growth rate is affected, which causes the slip of the epiphysis.
Another thing you said, this is common in children or adult with obesity,
Yes, sir.
rapid growth spurts,
Yes, sir.
and other endocrine problems.
Yes, sir.
How to differentiate an aseptic necrosis of femur? Because that is also common in this patient with obesity and endocrine problem like Cushing disease. How to differentiate from aseptic necrosis of femur from this SCFP?
Uh, Aseptic necrosis. So SCFE, it's caused due to the growth plate gets injured, and that causes slip of the epiphysis. Whereas aseptic necrosis can affect the head of the femur itself. And obesity causes it usually the stress of the weight of the person on the bones causes this thing. And the other endocrinal abnormalities, there is a loss of balance of growth hormone, sex hormones, and thyroid hormones, which affect the growth plate of the head of femur.
Since SCFP is bilateral.
Yes, sir.
Bilateral. Whenever there is more than one joint involved, we always think of systemic cause. What may be the underlying pathology, underlying pathophysiology?
For this, in this case, there was no loss of weight, loss of fever, so there was no other infections or anything involved. But okay.
Okay, read.
Thank you, sir.
Thank you. That was slot number 17. Coming up next, slot number 18. Final year student, Alankrita.
A very good afternoon to the respected judges, delegates, and the audience. My name is Alankrita Srivastava, and here is my case presentation. So my patient, sorry, sir. Timer start again. Sorry about that. So my patient is a 28-year-old multigravida female, a resident of Vijayapura. These are her case sheets. So she came with no chief complaints as such, but she came to BLD at 4 months of amenorrhea for an MTP. So since there is no chief complaint, there is no particular history of presenting illness, but in the history of present pregnancy, the first trimester was uneventful fairly. All we know that was an NT scan was not done. In the second trimester, since she was just at 16 weeks, quickening was not yet felt. And in the view of her previous bad obstetric history, which I will come to in the next slide, a chorionic villus sampling was done that revealed a genetically anomalous baby. So this is her obstetric history. Her score was gravida 4, para 2, living 1, aborted 1. Her first pregnancy was a normal vaginal delivery of a 3 kg female, stillborn at 8 months of amenorrhea and prenatally evaluated for intrauterine death. Her second pregnancy was a spontaneous abortion at 2 months of amenorrhea. Her third pregnancy is a female, 2.6 kg, currently 3 years old, alive, immunized, up to date, delivered through an LSCS, which was indicated due to fetal distress. And right now she presents with delayed developmental milestones and mental retardation, and 1 year back has been diagnosed heterozygous positive for ataxia telangiectasia. Her fourth pregnancy is the present pregnancy, 16 weeks, and CVS relieved a homologous positivity for the same. So she has been married for 8 years in a third-degree consanguineous marriage, and both the partners were subjected to a couple karyotyping, and they were also found to be heterozygous positive for the ETM gene mutation. Her menstrual history was fairly normal. Her cycles were regular. There was just a 5-day variation in her period of gestation as calculated from her LMP versus as calculated from the obstetric scans. Her past history and personal history were insignificant. Her family had a strong history positive for ATM gene mutation. General physical examination was also normal. All her vitals were within the normal limits. Her systemic examination was also normal. Coming to per-abdominal, the only positive finding we had was there was a slight bulge in the lower abdomen representing a uterus of 16 weeks and a transverse scar noted on the lower abdomen, most likely of an LSCS. And on auscultations, fetal heart sounds were not audible using a stethoscope. To summarize, a 28-year-old female came to our outpatient department with reports of a genetically anomalous baby. She had a bad obstetric history born out of a third-degree consanguineous marriage of previous 1 stillbirth, 1 spontaneous abortion, and 1 living child with delayed milestones. Both partners and their second-born child were heterozygous positive for ataxia telangiectasia. Chorionic villus sampling for the present pregnancy revealed the same. Patient had a strong family history for ATM gene mutation and came for an MTP. So since this is such a clear-cut case, there is hardly any differential diagnosis. But however, other conditions that could mimic this presentation might be the Meckel-Gruber syndrome, aneuploidy, infections like TB endometritis, some uterine structural abnormalities, and APLA syndrome. So some routine investigations were done, followed by some specific investigations. Now, these investigations were not done in our hospital, so the couple unfortunately did not have their chorionic villus sampling report, but they did have the duo whole exome sequencing test report, and this revealed heterozygous positivity for ataxia telangiectasia. This was the FISH done on the amniotic fluid of her present pregnancy. This revealed that there was no aneuploidy detected for chromosome 13, 18, or 21. And this was the report of the second-born child, which also indicated a heterozygous positivity for ATM gene mutation. So final diagnosis comes to be a gravida 4, para 2, living 1, aborted 1 with 16-week, 5-day period of gestation, previous 1 LSCS, reports of a genetically abnormal baby with CVS revealing homologous positivity for ATM gene mutation. So she was managed first by giving counseling to the couple, after which an informed written consent for MTP was taken. Then the patient was started on mifepristone, followed by misoprostol and antispasmodics, and after which, under good uterine contractions and oxytocin, she aborted. She expelled a male abortus. This is the male abortus weighing 106 grams, and this was the placenta weighing around 40 grams. Patient was told to report immediately in case of any complications. Fortunately, she did not have any. So coming to the discussion, as we all know, ataxia is just poor muscle control causing clumsy movements, and telangiectasia is small dilated blood vessels. This is also known as the Lewy-Barr syndrome, and it has a global prevalence of 1 in 100,000 live births. The mutation happens in the ATM gene located on chromosome 11q, 22, 23. It is an autosomal recessive type of inheritance, and the median survival rate is noted to be 19 to 25 years of age. Why this? Because eventually individuals succumb to their death either due to bronchopulmonary infections or cancers like leukemias, lymphomas, or rarely some types of gliomas. ALL is the most common cancer developing in these children. Clinical features can be ataxic dyskinetic syndrome, and this is only seen after the first few years of life, because this is when the child tries to sit up and stand up, and that's when parents can notice some type of truncal abnormalities. Then severe cognitive impairment is seen in 10% cases, reduced muscle power, telangiectasial lesions, some dermatological conditions like vitiligo, cafe au lait spots, graying of hair, and also some endocrine alterations can occur. These are the telangiectasial lesions. That is on the bulbar conjunctiva. We can see a butterfly-shaped rash pattern on the face and on the creases of the arms and legs. Investigations are clinical picture is very important, after which MRI of the brain is also done, which is very suggestive for ataxia. USG abdomen may reveal some hepatosplenomegaly. Blood tests can show a decrease in IgG, IgA. Genetic testing is very important. Alpha-fetoprotein is specific to ATM gene mutation, but not exclusive. And if there's a new variant, then immune blotting is done. As of today, there is no treatment for ataxia telangiectasia. However, short-term betamethasone and prophylactic antibiotic administration is given. Genetic counseling is very important because the siblings of these patients usually have a 25 to 50% chance of becoming asymptomatic carriers. And also, annual diabetes screening is very important in these children who cross the age of 12. In pregnancy, as we just saw, there can be pregnancy losses. And if she has an ataxic attack during labor, it can lead to motor ataxia, which causes difficult childbirth and even birth trauma. There are two conditions very similar to ataxia, that is Nijmegen-Breakage syndrome and ataxia telangiectasia-like disorder 1. Two recent advances that we know is that ET is now classified as one of the 4 chromosomal instability syndromes, along with Bloom syndrome, Fanconi anemia, and Nijmegen-Ricketts syndrome. And recent studies have also showed that acetyl-DL-leucine is also a possible treatment, but not yet established. These were my references. Thank you.
You mentioned where all you look for the telangiectasia in the body?
So bulbar conjunctiva, flexor creases of the arms and behind the knees, also seen on the face, on the bridges of the nose, like a butterfly pattern over the face, and sometimes over the chest also.
Another most common site is earlobe.
Yes, sir.
Looking for this telangiectasia in the conjunctiva is very difficult in children. Because this is photophobic and they tend to close their eye. And many times it's difficult to differentiate the conjunctivitis.
Yes, sir.
Okay, another thing. And what are the things you are going to follow up in the child or adult with the telangiectasia, ataxia telangiectasia?
So firstly, we have to follow up, make sure that the child is prevented of infections because they become very susceptible. We have to give them physical therapy, occupational therapy, speech therapy, and also some immune boosters, and screen them regularly for cancers and diabetes.
What cancers you screen them? How you screen?
So lymphomas, leukemias are most common. ALL is the most common in these children.
And what will happen to the alpha beta protein level in this?
So it will be elevated.
How much?
That I'm not sure, sir, but it will
Usually
be.
alpha protein in these children will be in hundreds.
Yes, sir.
If there is sudden elevation of alpha protein level from 100 to thousands, should always keep a possibility of developing cancers like hepatocellular carcinomas.
Yes, sir.
And I had a chance to report a case of ataxia telangiectasia in a 7-year-old child who had a sudden rise in alpha beta protein from 500 to 50,000, and it turned out to be hepatocellular carcinoma. Another important thing you have to avoid taking frequent X-rays or CT scan in these patients.
Yes, sir.
Because they are prone to develop a carcinoma.
Yes, sir. Radiation and
Radiation. You should avoid because many times they will have pulmonary symptoms.
Yes, sir.
But you should avoid taking X-rays and CT scan in these patients.
Yes, sir.
Why they will have cognitive impairment?
So because of mainly cerebellar and cerebral atrophy, there will be changes in basal ganglia and white matter also.
Predominantly there is involvement of cerebellum. However, cerebellum can also be inverted.
Congratulations, Alankata.
Thank you, sir.
Presentation. Can you tell us are there any preventive measures?
So as of today, there is no preventive, but there can be prenatal diagnosis. And individuals who know that they have family history of this gene, we can prenatally diagnose them by using tests like NIPT or chorionic villus sampling, as they have done. We just have to spread more awareness. And individuals who are trying to conceive, we have to inform them about the complications and that can happen with these children. And if they do conceive, then how to increase the lifespan. We cannot be sure that they will live a complete life. The median age is just till 25, but we can give information and awareness about how to protect them from any infections and regular screening. But as of now, there is no preventive definite measure.
So, when was the chorionic villus biopsy done?
Ma'am, 10
Yes.
weeks.
And why did they come at 16 weeks?
Ma'am, they had done this in Chennai. They had not done this in
Right.
Vijayapura, and they were not very sure if they wanted to keep the pregnancy or not.
So they were taking time.
Yes, ma'am.
Okay. So I'd like to just point out one very important point is that you should not display the case sheets. At the
Okay.
beginning, especially under the MTP Act, you are not supposed to reveal the identity of the woman. So,
Identity I had masked,
so
ma'am.
you should not put up any case sheets
Okay.
on any platform, including the hospital. We are going to mask the case sheets, right? So, and sir was asking about the alpha fetoprotein. So, in pregnancy, we test for alpha fetoprotein in the quadruple marker and the double marker test. Do you know any conditions where it will be raised in pregnancy?
Ma'am, any liver disorders in pregnancy, if she will have, it will be
More
raised.
commonly,
Not
the
sure.
neural tube depends and it is decreased in Down syndrome.
Okay.
Thank you.
Thank you.
Thank you. Coming up next is slot number 19, Prithvi, a final year student.
What's this one? Huh?
Good afternoon, everyone. My name is Prithvi, and I'll be presenting a case of unusual foreign body ingestion with intestinal perforation. Introduction: perforations are described as disruptions or lacerations of the full thickness of the wall of the hollow viscera. Gastrointestinal perforations have many cases, ranging from peptic ulcer disease, blunt penetrating trauma, iatrogenic injuries, inflammatory conditions, ischemic and obstruction, and rarely foreign body ingestions. Non-traumatic gastrointestinal hollow viscous perforations have received far less attention in the recent medical literature than the inflammations, malignant or traumatic lesions of the abdominal organs. The most common ingested food objects being like chicken bone and its fragments, dentures, toothpicks, and cocktail sticks. My patient is 10 months old from Vijayapura, and his mother was his informant, and his chief complaints were complaints of vomiting since 7 a.m. History of presenting illness. Patient was apparently all right 1 day ago, then he developed vomiting, acute in onset, gradually progressive in nature, non-projectile, non-blunt tinged, and not associated with hematemesis. He had 2 to 3 episodes since the morning containing constituents of milk and other complaints of pain, abdomen, intermittent type, which is gradually progressive. He had no history of fever, no history of loose stools, no history of cough. Past history: no history of past admission in hospital, no history of similar complaints in the past, nothing significant family history, antenatal history, book case, all the injections, regular checkups. He had a normal natal delivery and postnatal, there were no NICU admissions. Diet history: he had exclusive breastfeeding for 6 months. Complementary food was taken after 6 months. He had complete immunization, BCG, hepatitis, OPV at birth, and pentavalence at 6, 10, and 14 weeks respectively. General physical examination: he had no signs of pallor, icterus, cyanosis, clubbing, lymphadenopathy, edema, but had sunken eyes, vital signs. He had a pulse of 130 beats per minute, respiration 44 cycles per minute, and a BP of 84 by 50 mmHg. Anthropometry: he was of normal weight, height of 43 centimeters, and head circumference of 43 centimeter. Per abdomen examination, systemic examination, inspection. The contour of the abdomen was normal. Umbilicus was in midline. All quadrants move equally with respiration. No scars, sinuses, or engorged vein present. Palpation: there was a local rise in temperature. There was diffuse tenderness all over the abdomen. Abdomen is soft. Abdominal distension is present. Guarding is present. Rigidity was present, and no organomegaly. Percussion: shifting dullness was present, and no fluid thrill is there. Auscultation: vowel sounds were sluggish or absent. Respiratory system: trachea is in the midline. Contour of the chest normal. Chest is bilaterally symmetrical, bilaterally normal. Work of breathing has increased bilaterally, air entry and NVBS is heard. No added sounds are present. Cardiovascular system: S1 and S2 are heard, and no murmurs and no pericardial bulge is present. Differential diagnosis: perforated appendicitis, Meckel's diverticulitis, trauma, and foreign body ingestion. Investigations: CBC, CRP, urine test, bicarbonate, lactate, and albumin. Clotting factors: BT, CT, and prothrombin times. Cultures for E. coli and Enterocoli to check for subacute bacterial ingestion. And in CBC, we had increased neutrophil count, and CRP was increased. Ultrasound examination, erect X-ray was taken. that shows gas under the diaphragm. As you can see, ultrasound free fluid in the abdomen. Diagnostic tapping was done and drain placement was done, and 100 ml of purulent discharge was drained. Treatment. With adequate pre-operative preparations, emergency exploratory laparotomy was with a horizontal incision was done, and about 200 ml of bilious fluid was drained. Flakes were noted all over the small ball loops. Peritoneal lavage given, and a 0.5 into 0.5 centimeter perforation was noted in the fourth part of the duodenum. Foreign body was found at the site of perforation. It was milked away from the perforation site and retrieved with enterotomy in jejunum about 15 centimeters away from duodenal flexure. It was found to be the head of the chili, which you can see there. Primary repair was done, and duodenal perforation was done, and enterotomy was closed. Patient was diagnosed with burst abdomen on the post-operative day and was treated with re-exploration and secondary suturing. Following this, patient recovered with no post-op complications. Follow-up care, regular post-op imaging to ensure absence of complication like leak or abscess, regular inspection and care of surgical sites, counseling the patient and caregiver about the prevention of future ingestion incidents, and regular follow-up appointments to the monitor and abscess for any long-term complications like adhesion or bowel obstruction. Provisional diagnosis: 10-month-old baby presents with vomiting, has a peritonitis secondary to hollow viscous perforation. Conclusion: majority of ingested food pass through GI tract without any complication. In rare cases, the retained food foreign body may cause ulceration, perforation, bleeding, or localized stricture. This underscores the importance of close supervision. Therefore, in conclusion, although some intestinal foreign bodies can be managed with observation, high risk objects may require urgent or because this patient presentation may range widely from non-specific vomiting to life-threatening perforations and high level of clinical suspicions for ingested foreign bodies. These are my references, and thank you.
Congratulations, Prithvi. It's a good presentation. There were some corrections, suggestions I want to give. One is you have mentioned distension in the palpation, distension of abdomen, and that should be an inspectory finding. Right. Second is you told guarding was positive and rigidity was positive. When the rigidity is there, we don't mention about guarding. Rigidity is an advanced sign of peritonitis. When already rigidity has been established, you cannot elicit guarding. Okay. Third, can you tell us what are the common sites for foreign body infection and perforation in the GIT?
Common sites are peptic, duodenal regions, and ileocecal junctions, then in colonic regions.
More proximally, that is especially in the cricopharynx. Proximal part of the esophagus, isn't it? Cricopharynx is the common site for foreign body infection. Next comes your pyloric junction or ileocecal junction. Okay.
Another thing, whenever you are presenting cases related to children, don't say patient. You can say 10-year-old boy, 10-year-old girl, 10-month-old boy, 10-year-old girl. Another thing, what is the cause for ulceration in this case? Is it just mechanical?
Yes, mechanical injuries. Mechanical, and due to that chemical peritonitis blockers.
What is the age of the child?
10 months.
When does the pincer grasp will develop in a infant?
Sorry.
Pincer grasp. You have heard of palmar grasp and pincer grasp. Pincer grasp means the child should be able to hold the objects between thumb and index finger. Then only he can take something and get into the mouth.
Yes.
Can it possible 10-month-old child taking so much of a large head of a chili and put into the mouth?
I'm not.
Okay.
Oh, I think what sir is worried about is if it is a spicy thing in the mouth, the child will spit it out. How did this one enter inside?
Ma'am, that was
At 10 months of age.
that was
what
the head
sir
of
is
the
worried about.
that was head of the chili, ma'am. It was
We don't know other part is digested or not digested, or somebody put it in.
no, ma'am. The mother was peeling the chili, ma'am, and the end part was remaining. So the baby was playing on the ground, and he picked it up and ingested it.
What as we know, all pediatric this one, what we call it as are happening early, isn't it?
Yes.
Physical class, what we read, it was late at that time, in the maybe 20th, 30th back. Nowadays, their milestones are occurring earlier than before. That may be one reason, isn't it? For
Yes. Yes.
picking up and swallowing. And quite a long foreign body. It's difficult to digest.
Yes.
Now difficult to swallow. I don't know. Some miracle might have happened to swallow that long foreign object, isn't it? Mhm.
Thank you, sir.
Thank you. Coming up next is slot number 20, a second year student, Narahari.
Esteemed judges and all the fellow presenters, I, Narari of second phase MBBS, I'm going to present an interesting case about a 40-year-old male who is presenting with chronic pulmonary aspergillosis. As the title states, unmasking the hidden threat, a case of chronic pulmonary aspergillosis mimicking tuberculosis. So let's look into it. Introduction. Chronic pulmonary aspergillosis is often overlooked but increasingly recognized consequence of chronic lung disease, particularly in individuals with the history of pulmonary tuberculosis. CPA can pretend as recurrent TB or other chronic lung conditions, leading to delays in the diagnosis and treatment. In this report, we delve into an intriguing case of a 40-year-old male whose persistent lung symptoms unraveled a clinical mystery, highlighting the importance of vigilance and the far-reaching implications of the patient care. Case report. Patient overview. The patient, a 40-year-old male with the history of successfully treated pulmonary tuberculosis, was haunted by a relentless cascade of symptoms that refused to abate. For 7 long months, he was tormented by chronic cough, copious expectorations, breathlessness, periodic fever, and gnawing chest pain. A clinical mystery. The initial investigations painted a confound picture. Chest X-ray revealed bilateral upper lobe consolidations with the bronchiectasis and cavitary lesions, findings that were unsettlingly similar to the previous TB infection. HRCT scans further complicated the case, suggesting the presence of aspergillomas. Investigations. Blood investigations showed mild leukocytosis, anemia, elevated erythrocyte sedimentation rate. The patient's vitals were stable with normal blood pressure, pulse, and oxygen saturation. The turning point came in the form of sputum culture. As the results came in, the presence of Aspergillus species in the patient's sputum illuminated the true nature of the illness. Chronic cavitary pulmonary aspergillosis, CCPA. The cause underscored a critical lesson for clinicians, the need for heightened awareness of CPA in post-TB patients, a condition often hidden in plain sight. This is the X-ray showing the consolidations on the upper part of the lobes of both the lung. And this is the HRCT scans, which shows cavitary lesions on both the lungs. So this is the CT scan, which shows we can appreciate the cavity lesions here. Treatment. With the diagnosis confirmed, the patient embarked on a therapeutic journey fraught with challenges. He was started on an oral itraconazole, 200 mg twice daily for an extended course of 6 months. The patient's socioeconomic status posed a significant barrier to accessing more intensive therapies such as intravenous antifungals or surgical intervention. This aspect of the case brings to the forefront often overlooked but deeply impactful role of the socioeconomic factors in healthcare delivery. Follow-ups and prognosis. The regular follow-ups were recommended after 3 months to assess the patient's response to treatment and to monitor the potential complications such as hemoptysis or progressive pulmonary fibrosis. His journey underscored the importance of close monitoring and the potential for the positive outcome in the timely and appropriate intervention. Discussion. The case offers several key takeaways. Diagnostic dilemma. The case highlights the diagnostic challenges inherent in differentiating between CPA and recurrent TB. It emphasizes the need for comprehensive diagnostic strategies, including microbiological and radiological assessments, especially in patients with history of TB. Thank you.
Narari, please tell me, is it a hypothetical case or real case?
It's a common case, sir.
No, it's just is it a hypothetical case or real case you are described?
So, it's like the as per the articles which I have read, they shows it shows like 6.5% to like 6.5% to 18.5% of recurrence in post TB patients, sir. And it mostly occurs in the immunocompromised patients. And normally in a healthy human, it is present in 30% of healthy human. It is present in its sputum, but it doesn't cause any symptoms because of the because in case of post TB patients, there's a immunocompromised state which helps in the.
Please tell me, the way you are narrating it like a chat GPT created case.
No, sir.
Then tell me from which unit you have taken this case.
Sir,
From which unit you have selected this
fifth
case?
unit, sir.
Fifth unit.
Yes, medicine.
Who was the teacher?
So I asked from PGs.
Is it aspergillosis or still tuberculosis is ongoing?
No, sir. Tuberculosis was cured, and after 6 months, he was showing with aspergillosis.
How you confirmed? What was the confirmation?
So, from the sir.
How you confirm that there is no tuberculosis?
So, by doing the sputum test, sir, sputum culture.
Which test?
So, the ZN staining, ZN, Zeal-Nielsen staining.
What is the sensitivity and specificity?
No,
it is very less sensitive. So many times it can be negative in a tuberculosis patient, isn't it?
Yes.
So, what is CB-NAT?
CB-NAT is a cartridge-based nucleic acid amplification test.
Was that test done in this patient?
Yes, sir. It was done previously, but it showed negative. Then the like after post TB patient, and then aspergillosis, like he showed symptoms of aspergillosis, and with the help of HRCT scans, they and the with the help of sputum culture, they proved that it was chronic cavitary pulmonary aspergillosis.
Clinically, what signs were there?
Clinically, expectoration, copious expectorations, and cough, the sputums, like copious expectorations, and
Say cavity, what sign you get? Cavity.
so the fungal balls, aspergillomas.
Cavity, what is this? How you diagnose clinically cavity?
So using CT scans or
Clinically.
clinically, sir. I know it is.
Pneumonia.
Sir,
Can it be pneumonia?
pneumonia doesn't cause cavity lesions, sir. It causes accumulation of the.
Pre-existing tuberculosis, there can be pneumonia. Secondary bacterial.
Yes, sir. All the sir in after post tuberculosis patients, they are mostly susceptible to opportunistic infections. All the aspergillosis and conidia and conidia sporothrix, and also pneumonias.
When was he diagnosed with tuberculosis, or when was he declared cured? Previously, how many months back?
So 6 months back, ma'am.
So has he taken the full treatment? But do you know that he has completed his treatment and declared cured?
Uh, yeah.
Because unless he's declared cured, there might be still a persisting tuberculosis infection only here.
To check.
You have reports, I think you should go back and see.
Yes. Thank you.
Coming up next is slot number 21, a third year student, Sanskriti.
Good afternoon, everyone. I'm Sanskriti Gormode, and today I'll be presenting a case of panophthalmitis from the Department of Ophthalmology. So let's begin with the introduction. Panophthalmitis is an intense purulent inflammation of the whole eyeball, including the Tenon's capsule. Tenon's capsule is the facial sheath of the eyeball. The disease usually begins either as purulent anterior or purulent posterior uveitis, and soon a full-fledged picture of panophthalmitis develops, following through a very short stage of endophthalmitis. Coming to the etiology, the causes of panophthalmitis can be infectious, non-infectious, endogenous, and exogenous. Under the infectious, it can be caused due to bacteria such as Staphylococcus, Streptococcus, fungi such as Candida, Aspergillus, viruses such as herpes simplex virus, varicella zoster virus. Non-infectious causes include trauma or any previous surgery. Endogenous causes include endophthalmitis. Exogenous causes includes contact with contaminated substances. So here is the case history of a 63-year-old male who presented to the OPD with the chief complaints of pain and loss of vision in the left eye since 15 days. Loss of vision in the left eye is insidious in onset and gradually progressive in nature. Pain in the left eye is throbbing in nature, severe and continuous, and non-radiating. There is a history of profuse watering in the left eye, which is continuous in nature since 15 days. There is a history of trauma with a steel ball 20 years back, which subsided on taking medication. There is no history of discharge, colored halos, photophobia, and diplopia. Under the general physical examination, the 63-year-old male patient is moderately built and nourished and is well oriented to time, place, and person. He is showing signs of pallor, but the icterus, clubbing, cyanosis, lymphadenopathy, and edema is absent. Under the systemic examination, in CVS, S1 and S2 are heard with no heart murmurs. In respiratory system examination, normal bilateral vesicular breath sounds are heard. Per abdomen, abdomen is soft and non-tender. In CNS, there are no focal neural deficit observed. Under the ocular examination, external appearance, okay, so the lower lid has ectropion. Ocular motility is painful. Conjunctiva is showing diffuse congestion, chemosis, and keratinization. The sclera is also congested. Cornea, there is superficial vascularization, leukomatous opacities, and thinning in all quadrants. The pupil cannot be assessed. The visual acuity, the patient is unable to perceive light, that is, he is PL negative. So, according to the patient's history and ocular examination findings, these can be the differential diagnosis: endophthalmitis, orbital cellulitis, and keratitis. Endophthalmitis is the inflammation of all the structures of eyeball, that is uveal tissue, retina, vitreous chamber, the anterior chamber, posterior chamber. Orbital cellulitis is the acute infection of the soft tissues of orbit, and keratitis, we know that it is the inflammation of cornea. We further carried out investigations such as B scan of left eye, that is the bright scan ultrasonography of left eye. It revealed choroidal detachment, calcification of sclera. Dot and membrane echos and vitritis. We see dot and membrane echos and vitreous when there is vitritis. Therefore, based on the history, ocular examination, and investigations, we came to a provisional diagnosis of left eye panophthalmitis. Treatment modalities. Treat the cause by medical treatment, which includes systemic antibiotic, topical antibiotics, anti-inflammatory, and analgesics. Surgical treatment includes evisceration. As for this case, it was treated by IV ceftriaxone, amikacin, tablet Zerodol SP, along with moxifloxacin, tobramycin, and atropine eye drops. Evisceration operation is to be planned. At last, I would like to conclude by saying that panophthalmitis is a rare disease of eye and also an ocular emergency. It can lead to serious complications such as orbital cellulitis, cavernous sinus thrombosis, meningitis, or encephalitis. These are my references. Thank you.
That's a good presentation, Samkruti.
Thank you, sir.
Was there any surgery planned in this patient?
Sir, we are planning evisceration operation if the patient does not respond well to medical treatment.
What treatment was given in this patient, you told?
We gave medical treatment.
Patient was all right with medical line of treatment, or patient needed surgery?
Sir, we gave him medical treatment and asked him to come for follow-up, but the patient insisted on he wanted to shift to another place or like bigger cities.
Patient has not taken complete treatment at this center.
No, sir. He has just taken medical treatment. We asked him for follow-ups. He's insisted like he'll shift to some big cities.
In such cases, you have to better follow up the patient. Even though they are not taking complete treatment in our hospital, you can take their number, you can follow up the patient, isn't it?
Yes.
Wherever patient has gone, whatever mode of treatment he has undergone. What are the sequelae you wrote, complications of panophthalmitis?
Sir, complications of panophthalmitis mostly is meningitis. Then it can lead to orbital cellulitis, cavernous sinus thrombosis.
You know how cavernous sinus thrombosis is present?
Sir, cavernous sinus thrombosis is blood clot is formed in the cavernous sinus. The cavernous sinus is situated behind the eye and beneath the brain, so which can lead to facial pain, other complications.
From this, there will be some sort of external ophthalmoplegia.
Yes, sir.
Which cannot be elicited in the affected eye because already it has undergone panophthalmitis. You
Yes.
can look for that signs in other eye, opposite eye.
Yes.
Good.
In the treatment part, you mentioned treat the cause. What is the cause in this case?
Sir, in this case, the cause is, I told in the beginning that it can be infectious and non-infectious.
In this case, what was
in
the
this-
cause?
In this case, he presented to, he said he had a trauma with a steel ball 20 years back. I know it's very long period, but maybe the patient has not gone treatment and it had lead to orbital cellulitis and he's
It may
come.
be just an association, it may not be causation.
Okay.
You mentioned just a trauma where? Trauma to what?
Trauma to the eyeball.
Trauma to the eyeball. It
Right.
took nearly 20 years to present as a panophthalmitis.
Sir, usually it does not take that much time, but the patient was, he told that much history.
Suppose if you don't treat the panophthalmitis, what is the risk to the other eye?
Sir, if we don't treat panophthalmitis, it can lead to systemic ophthalmitis, which can affect the left other eye as well.
What is the difference between enucleation and evisceration?
Sir, evisceration is the removal of entire contents of the eyeball, and enucleation we leave behind sclera. But in this case, enucleation is contraindicated, as if we leave some part of sclera, it can lead to further infection. Thank you.
Next, we have slot number 22, third year student, Bhamini.
Good evening, everyone. Respected judges, professors, audience. Today I'm going to present a case study on breast lump, particularly about breast cancer. As we all know, it is not a rare presentation or rare type of disease. It's quite very common, but this topic is of significant importance for all of us, even though it is not a rare condition, because as we all know, breast cancer is globally one of the very most common cancer across the world, and it is second most common cancer in the in India, followed by cervical cancer. If we look into the background and statistics of the breast cancer, around 7.8 million women alive are diagnosed with breast cancer in the past 5 years, and the incidence rate is about 2.3 million each year. So the mortality rate is 685,000 per year. So it is of significant importance for all of us for our day-to-day clinical practice. Cancer cells begin to proliferate inside the ducts or the lobules of the breast. The earliest form, the in situ, is not life-threatening and can be detected in early stages. This creates tumors that cause lumps or thickening. Hereby presenting a case of a 55-year-old female who hails from Vijayapura. She is unmarried. She comes with the chief complaints as complaints of a lump in the right breast since 8 months and ulceration over the skin in the right breast since 5 months. The patient was apparently all right 8 months ago when she developed a lump over the right breast in the upper outer quadrant, which was insidious in onset, rapidly progressive in size. It was initially of 3 by 2 centimeters and grew to 6 by 6 centimeter, and it was painless. Patient also gives an history of an ulcer overlying the skin, which was about 1 by 1 centimeter and now 3 by 2 centimeter, involving the nipple areola complex, discharging pus, and bleeds on touch. There was no history of nipple discharge, nipple retraction, trauma, fever, loss of appetite, or significant weight loss. There is no history of taking oral contraceptive pills or hormone replacement therapy. There is no history of irradiation to the breast as well. In the past history, she was a paraplegic since 2 years. Other than that, there is no abnormal past history. And the personal history is also normal. She attained her menarche when she was 14 years old, and she had regular cycles of 4 to 5 days. She attained menopause, that is 5 years back, when she was 50 years. She is a nulliparous woman. Family history is nothing significant. Everyone in the family are healthy, and there is no history any other malignancies such as pancreatic, colorectal, or ovarian cancers in the family. General physical examination and systemic examination reveals no abnormal findings. Breast examination. On inspection, a right breast appears bigger than the left. A solitary lump of size about 6 by 6 centimeter is seen in the upper outer quadrant, which becomes prominent on bending forwards. Skin over the swelling is reddish. There is no dilated or tortuous veins. The ulcer overlying the nipple areola complex measures approximately 3 by 3 centimeter. Margins are well defined. Edges are everted. Floor is red with unhealthy granulation tissue, showing seropurulent discharge and blood. There is no satellite nodule seen, no powder-orange appearance or dimpling or puckering, no cracks or eczema over nipple areola complex. There is no swellings or ulceration in the axilla or supraclavicular region. The opposite breast, that is left breast, appears normal. No visible swelling. Contralateral axilla is normal. On palpation, right breast is warm, non-tender. A single lump measuring about 6 by 6 centimeter with irregular surface, well-defined borders, hard in consistency, is felt over the upper outer quadrant, fixed to the skin. Skin is not pinchable, moving freely over the pectoralis major. It is not fixed to the bone. An ulcer is seen measuring about 3 by 3 centimeter over the nipple areola complex. It is non-tender, indurated, base is free from the underlying tissue as well. The other inspectory findings were confirmed. It bleeds on touch and the surrounding skin is erythematous. There is no discharge from the nipple. Regional lymph nodes. The axillary lymph nodes in the right axilla central group is palpable, and the supraclavicular lymph nodes are not palpable. The axillary lymph nodes on the left axilla is normal. Contralateral breast is normal. The provisional diagnosis. A 55-year-old lady presenting with the painless, rapidly growing hard lump in the upper outer quadrant of the right breast, along with an ulcer involving the nipple areola complex, with everted edges and induration with fixity to the skin, not fixed to underlying muscle. There is no other skin changes, chest wall involvement, likely to be a malignant lump of the breast. Staging is T4B, N1, and M0. The differential diagnosis for this case could be benign breast lump like fibroadenoma. Even though fibroadenoma is not common in postmenopausal women, and it does not turn into malignancy, but sometimes can be mistaken as a lump in the physical and radiological examinations. It has the clinical similarities of well-defined and palpable mobile lump and phylloids tumor. Malignant breast lump is breast cancer and Paget's disease of nipple, where there is erosion of the nipple and eczema around the nipple. It is intraductal carcinoma of the breast. And investigation, mammography is done for the screening. USG was suggestive of BIRATS grade 5. FNAC was done for this patient, which revealed infiltrating ductal carcinoma. CCT chest, abdomen, and pelvis was done for to rule out any metastasis. The management follows modified radical mastectomy. Under general anesthesia, modified radical mastectomy of the right breast was done using Stewart's incision, providing access to the removal of entire breast tissue, including the nipple areola complex. Level 1 and level 2 axillary lymph nodes were carefully dissected. Suction drains were placed. The specimen was sent to histopathological examination and receptors. We are waiting for the histopathological examination. It hasn't come yet. This is the picture showing modified radical mastectomy, which involves removal of entire breast tissue, including nipple areola complex and axillary lymph node dissection. This is the levels of axillary lymph node dissection based on the location of pectoralis minor muscle. Her follow-up plan is she was operated a week ago. We have to inspect her wound and drain should be checked. Dressing has to be changed. After discharge, she is supposed to come for regular follow-ups. And then we can plan for her adjuvant therapy, physiotherapy, lifestyle modifications like diet, exercises, and psychosocial support to be given. The conclusion of this case is in the management of breast cancer, strict adherence to the treatment protocol and compliance with follow-up care is important to achieve the best possible outcomes. The importance of regular breast cancer screening, particularly in women with risk factors such as nulliparity, postmenopausal, and absence of known genetic factors, plays a vital role. Treatment involves a multidisciplinary approach, including expertise of surgeon, oncologist, radiologist, pathologist, psychiatrist, and caregivers. These are my references. Thank you.
Ma'am, it was a good presentation.
Thank you, sir.
I want to know a few things from you.
Yes, sir.
You are told the staging,
Yes.
that is T status, M status, M status. Under which stage it falls? Stage grouping.
Stage 3, sir. 3B.
Stage 3. Stage 3B comes under locally advanced breast carcinoma.
Yes, sir.
You know,
Yeah.
what is the standard treatment protocol for locally advanced breast carcinomas?
So modified radical mastectomy.
It is always neoadjuvant chemotherapy. Okay, what we call anterior chemotherapy. But there would have been some systemic metastasis also. So better to give standard mode of treatment is give a neoadjuvant chemotherapy or anterior chemotherapy of 1 or 2 cycles, then do surgery. That is standard protocol. Not doing surgery, even though it is operable, don't go ahead with surgery first because already the patient is in stage of locally advanced breast cancer. Okay. Second, in examination you have mentioned, though it was not fixed to underlying pectoralis major muscle.
Yes.
You did mention there was no bone fixity. When there is no involvement of underlying pectoralis major muscle, where is the question of bone fixity? Isn't it? We need not mention that. It was not needed. Then you have mentioned about receptors, receptor negative. Which receptor you are interested in?
So ER/PR receptors.
Hormone receptors.
Hormone receptors.
ER and PR receptor status.
Yes, sir.
And did you get the reports?
No, sir. We are still waiting for
Yet to
get
get
to
the
receive.
reports.
Yes, sir.
What is your plan if ERPR positive status is there?
Sir, ERPR positive, if it is there, I would like to give chemotherapy of
Chemotherapy already you are planning for operative chemotherapy.
tamoxifen.
Hormonal treatment.
Hormonal.
Then since it is a hormone dependent tumor and ERPR positive status is there, you have to give even hormonal treatment and adjuvant therapy.
Yes, sir.
Can you name some drugs?
Sir, CDK4 inhibitors or
Some hormonal measure treatments,
um,
hormonal therapy. You were telling that.
tamoxifen.
Tamoxifen.
Yeah.
There are again first line, second line, third line drug. Normally with first line drug, that is tamoxifen. What are the side effects of tamoxifen, you know?
So weight, hair loss and
See,
nausea, vomiting. And
commonly cause endometrial carcinoma,
okay.
DVTs, then cataracts, etc.
Yes.
That's a good presentation.
Thank you, sir.
Just what are the risk factors for breast cancer?
Ma'am, risk factors are there are many risk factors. Main
What
is
risk factors are present in this patient?
in this patient, it is nulliparity, and she's a postmenopausal lady, and there is no genetic, there is no familial involvement.
How to prevent breast cancer?
Ma'am, screening for all the women aged above 35 years of old, when they are completed their family, mammography should be done for screening.
Completed family or not, but screening is there.
Yeah.
Mammography, and which is the best screening method?
USG is best.
No more
Self breast examination. Thank you.
Coming up next is slot number 23 from third year, Vaishnavi.
Yeah. Good evening, everyone. I'm presenting a case of neck of femur fracture. So, neck of femur fractures are although very more common in elderly, but when presented in a younger age group, they are having a high risk of morbidity, and the management strategy must be carefully selected based on the type and severity of fracture. CC screw fixation is typically employed for undisplaced or minimally displaced fractures, aiming to stabilize the bone but also preserving the natural joint. However, if there is a case of failure of fixation of CC screws, then and there's a involvement of acetabulum, then total hip replacement surgery will be opted. So here I have a case of the same presentation. The patient named Ravi is a 47-year-old male who's a truck driver and had a history of fall from the truck, due to which he had a neck of femur fracture. The initial treatment given was CC screw fixation, but the outcome was implant failure with persistent hip pain and difficulty walking. The chief complaint of the patient was difficulty in walking since 9 months and pain in right hip region since 6 months. History of presenting illness was patient was apparently all right 9 months back when he had a history of fall from truck and developed pain over right hip, which he was admitted to civil hospital and had underwent the surgery of CC screw fixation for the same. Post-op period was uneventful and nil weight bearing, but for a period of 1 month. But the patient started with full weight bearing without proper consultation. That led to implant failure and had difficulty in walking even for 15 meters. He continued the same, but after 4 to 5 months, he came to BLDE hospital and was explained about the implant failure and need for the surgery. Currently, the patient was having difficulty in walking. Patient used stick to walk, but was also having pain while walking even for 100 meters. The pain was insidious in onset, gradually progressive, non-radiating, crushing type of pain. The patient had difficulty in squatting, sitting cross-legged, and carrying out day-to-day activities. There was no history of morning stiffness, any other joint immobility, tingling, numbness, back pain,
fever, weight loss, night cries, or excessive bleeding. The general physical examination and systemic examination were all normal. The gait that patient presented was assisted antalgic gait, indicating pain during ambulation. Muscle wasting was notable on the right hip, right thigh, leg, along with gluteal wasting on the right side, suggesting significant muscle atrophy. Surgical scar was a well-healed scar of 6 into 1 centimeter at the right hip, corresponding previous surgical intervention. Pain at anterior joint line tenderness with painful limitation during flexion, internal rotation and external rotation was present. Instability test proved positive for Trendelenburg and telescope test. When the measurements were taken for both right and left hip, we could see that there was a shortening of hip at right leg, and there was 2 centimeter muscle wasting and supratrochanteric shortening of Bryan's triangle. So the differential diagnosis could be different type of hip fractures such as intertrochanteric and pelvic fractures, osteoarthritis of hip, avascular necrosis of hip, pathologic fractures, hip dislocation, infections such as septic arthritis, osteomyelitis, inflammatory arthritis such as rheumatoid arthritis. This was the X-ray that was taken before his CC screw fixation. And you can see the overriding of greater trochanter and visible lesser trochanter, and there was a fracture at neck of femur. This was taken after the insertion of CC screws. 3 CC screws were fixed. The CT was performed so that we could understand the involvement of acetabulum and then further think about the surgical procedure. Since the acetabulum was involved, we had gone for total hip replacement surgery. The provisional diagnosis which we came to conclusion was failed CC screw fixation of right-sided neck of femur fracture with associated complications such as significant muscle atrophy. Treatment was surgical intervention, wound and pain management, rehabilitation, and follow-up. For treatment plan, since the patient is less than 60 years, and when he was first gone to hospital, it was less than 3 weeks. So he was given close reduction, internal fixation, plus CC screw fixation. But due to acetabular involvement, complications, and all, he was treated for total hip replacement surgery. This is the video of showing total hip replacement surgery, pre-operative assessment, anesthesia and positioning, incision and exposure, screw removal was taken place. Then hip dislocation was done, femoral head resection, as you can see. Then femoral acetabular preparation, femoral canal preparation was done. Acetabular preparation to place the cup, liner, and then for the holding of acetabular head. For femoral canal preparation for insertion of femoral stem. Then the implantation was done. Everything was impacted together firmly. The trial of implants was done with flexion abduction inside, and then original implants were put, and then wound closure taken place. So post-surgery, this is the X-ray. As you can see, there were 2 screws that were fixed. One is posterior superiorly and other one was posterior inferiorly. When the line drawn between lesser trochanter and inter-teardrop line, they were parallel, showing no leg length discrepancy. So for wound and pain management, we gave him sterile dressing, and for post-op day 3 and post-op day 5, wound was clean, no discharge, staples were intact. So antibiotics, analgesics, and antacids were given. For pain management, we gave him Dynapar and paracetamol. Rehabilitation, we gave him static and physiotherapy of static and dynamic quadriceps strengthening exercises, active ankle foot exercises, bilateral lower limb abduction. But the patient was advised to strictly avoid flexion, internal rotation, sitting cross-legged. Follow-up was day 12 for post-op for suture removal, then 6-week follow-up period, and 3 months and 6 months. The restrictions that was advised was squatting, sitting cross-legged. And conclusion, this case underscores the importance of careful and individualized approach to managing complex neck of femur fractures, especially in younger patients. The transition from failed fixation to total hip replacement, along with the implementation of a robust rehabilitation program, highlights the need for multidisciplinary care to achieve the best possible outcome. Vigilant follow-ups is crucial to monitor recovery, prevent complications, and ensure long-term success of patient. These were the learning points from this case: failed fixation considerations, comprehensive assessment, rehabilitation, and multidisciplinary care. Thank you so much.
It was a good presentation.
Thank you, sir.
Why in rehabilitation the sitting cross-leg and squatting is restricted?
Sir, before even the surgery, he was having
After surgery.
severe pain with that. So to not increase the pain and putting the pressure at the joint, we had advised.
EHR is done to give him a chance to put pressure on the joint. Okay.
Yes, sir.
So why we allow certain activities and why we not allow certain activities?
Containment.
The chances of dislocation are more with the cross leg or
Yes.
squatting. With cross leg, there may be abnormal pressures which might put the implant into some sort of abnormal pressures which can cause loosening. Okay?
Yes, sir.
So sitting in cross leg is not allowed.
Okay, sir. Thank you so much, sir. Thank you so much.
Small announcement for the students. The sign-up sheet so far will not be taken into consideration. Attendance will be taken after the event is done. The judges, please note the next presenter, slot number 24, third-year student, Vineet.
Good evening, everyone. My name is Vinith, and I am here to present a case of acute myocardial infarction. Introduction. Ischemic heart disease is defined as acute or chronic form of cardiac disability arising from imbalance between myocardial supply and demand for oxygenated blood. Globally, it is estimated that IHD or coronary artery disease affects 3 to 4% of world's population. A rising trend in incidence in the countries with increasing urbanization and emerging economies is thus higher prevalence. Major risk factors for this disease is obesity, lipid abnormalities, type 2 diabetes mellitus, and hypertension. So here is the case. Patient, 52-year-old male from Bijapur, presented with a complaint of severe chest pain since 6 hours. History of presenting illness. Patient was apparently all right 6 hours back when he developed chest pain, which was acute on onset and progressive in nature. Chest pain was located at the center of the chest and was radiating to back. Pain was dull aching in nature and was aggravated on exertion with no relieving factor. It was associated with profuse sweating and mild dyspnea. There is no history of giddiness or syncope, no history of vomiting, preceding fever, or past chest pain. Past history. Patient is a known case of hypertension since 8 years and diabetes mellitus since 6 years. He is not a known case of asthma, tuberculosis, epilepsy, nor underwent any previous surgeries. Drug history. Patient is on medications for hypertension and diabetes mellitus. There is no significant family history. Personal history, diet, he is vegetarian, appetite is normal, sleep is reduced, and he has no habits. General physical examination. Patient is a 52-year-old male who is moderately built and nourished. He is well oriented to time, place, and person. Vitals are all normal with no pallor, no icterus, no clubbing, no cyanosis, no palpable lymph nodes, and edema is absent. Systemic examination. CVS. Pulse rate is 70 beats per minute. BP is 126 by 84 mmHg. Rhythm is regular. Character is normal. Condition of vessel wall is normal. There is no radioradial delay, no radiofemoral delay, and peripheral pulsations are all normal. Venous system, no visible JVP, so it is normal. Central CVS. Inspection. Shape of chest is scaphoid. There are no visible scars or dilated veins. Apical impulse seen in left fifth intercostal space of chest medial to mid-clavicular line. Any other pulses are not seen. Palpation. No local rise in temperature. Apical impulse felt at left fifth intercostal space medial to mid-clavicular line. No parasternal heave or epigastric pulsations. No palpable sound or thrills. Percussion. Left heart border correspond to apical impulse. Right heart border is located to retrosternal. Auscultation, mitral area, tricuspid area, pulmonary area, aortic area, all S1 and S2 heard. No murmurs and thrills are heard. Other systemic examinations are all normal. Differential diagnosis. It could be acute coronary syndrome, aortic dissection, mild pulmonary embolism, and non-cardiac less likely such as GIRD and costochondritis. Investigations. The main investigations which are done are ECG and cardiac enzyme markers, such as troponin I, CPKMB, and LDH. Other hematological investigations are done such as CBC, urine routine, random blood sugar, HbA1c, serum creatinine, and lipid profile. Further, chest X-ray and coronary angioplasty is done. Here is the ECG when patient presented to the hospital. As you can see, there is a clear ST segment elevation in V2, V3, V4 leads, which is suggestive of anterior wall MI. Here you can see there is increased in troponin I value and increased CPK-MB value. Chest X-ray is done, which is normal. Coronary angioplasty is done, which showed there is a blockage in proximal LAD and was corrected with quantum apex balloon. Provisional diagnosis. Provisional diagnosis of this case is acute coronary syndrome, most likely acute myocardial infarction with no complications, with comorbid cases of essential hypertension and type 2 diabetes mellitus. Treatment modalities. We should immediately admit the patient in ICU and analgesics should be given, such as morphines. Nitrates are given. Antiplatelets such are given, such as ecosprin. Thrombolytics such as tenecteplase is given. Heparins, statins such as atorvastatin is given. Insulin and antihypertensive since he is suffering from essential hypertension and type 2 diabetes. After patient becomes stabilized, coronary revascularization is done through PTCA and bypass surgery. Here, outcome and follow-up. For the follow-up, patient was found following drug for 1 month and was scheduled to revisit after 1 month. After 1 week, there was following improvement in ECG. As you can see, the ST segment elevation is reduced in V3, V4, and V2 leads. Conclusion. This is usual presentation of acute myocardial infarction with severe retrosternal chest pain, which at a times radiates to back or left arm. Patient was suffering from comorbid conditions such as essential hypertension, type 2 diabetes mellitus, which are also the risk factors for ischemic heart disease. It is very important that patient should be hospitalized as soon as possible and to be thrombolized within 6 hours of time span, which is also called as golden hour, which help in minimizing the mortality and morbidity. Patient education regarding follow-up visits, lifestyle management, and regular examination will help in reducing the complications. Yes, it is a common case, but as a future clinician, we will encounter these cases. So I thought of presenting this case, but here are some rare presentation of acute myocardial infarction, such as patient with present with just exertional breathlessness, just giddiness or syncope, referred toothache presenting to dentist, and silent MI with people who are old age and suffering from diabetes mellitus. Here are my references. Thank you.
Thank you, Mili. That's a nice presentation. So these patients, what complications they can develop?
Sir, there are 2 types of complications such as electrical and mechanical. In electrical, patient may suffer from arrhythmia, and in mechanical, left ventricular hypertrophy and papillary muscle damage, septal damage, and papillary muscle failure.
What do you mean by silent MI?
Sir, silent MI is patient with no symptoms, and it usually occurs in patients who are old age and suffering from diabetes mellitus.
Have you heard fringe metals angina? What do you mean by that?
No, sir, sorry.
What are the risk factors? Can you enumerate all the risk factors?
Mainly coronary artery disease mainly occurs to atherosclerosis, rarely occur to aortitis, vasculitis. The risk factors for atherosclerosis are modifiable, non-modifiable. In non-modifiable, there can be age, sex, genetic factors. In modifiable disease such as hypertension, diabetes mellitus, dyslipidemia, hypercholesteremia, and hypercholesteremia, smoking, alcohol can be present.
non-modifiable risk factors?
Non-modifiables are age, sex, genetic factors like familial history, patient who is twin and with the twin which occurs myocardial infarction, he can also get myocardial infarction.
What are the recent advances? Any newer drugs, in the management of MI? Thrombolytics.
Sir, thrombolytics, fibrin selective thrombolytics are used such as tenecteplase for immediate management of the myocardial infarctions.
What are the complications of thrombolysis?
So complications of thrombolysis, sir, recurrent bleeding.
And doing thrombolysis, what complications you anticipate?
So patient is susceptible for bleeding while undergoing surgery.
Okay.
Congratulations, Vinith, for your nice presentation.
Thank you.
You have substantiated your cause of presentation, though it was a common disease, more common cause of sudden death. You have substantiated that. May I know some more modes of presentation? Many a times patient with acute MI can present to surgery OPD. What could be the mode of presentation? Especially inferior wall MI patient can present to us with dyspeptic symptoms. We may confuse for acute gastritis, acute peptic ulcer disease. In fact, they are suffering from acute inferior wall MI.
Referred pain may occur to umbilicus.
Yeah. That's why better to rule out life-threatening myocardial infarction in such individuals whenever they are high-risk criteria, especially known diabetic, known hypertensive patient, already who have suffered from previous ischemic heart disease, etc. Okay, good.
Thank you. Coming up next is slot number 25, Meghna, a third-year student.
Good evening, everyone. Today I'll be presenting on a Good evening, everyone. Today I'll be presenting on a rare cause of external auditory canal polyp, nodular fasciitis. To begin with the patient's history, a 39-year-old male present with the mass in the right ear since 15 days, which was insidious in onset and rapidly progressive in nature. There were no aggravating or relieving factors. Patient also experienced right ear pain since 15 days, which was insidious in onset, gradually progressive in nature, dull aching type, with no aggravating or relieving factors. It was associated with ear discharge since 15 days, which was insidious in onset, gradually progressive in nature, minimal purulent bloodstain, and non-foul smelling, with no aggravating or relieving factors. Patient also complained of associated reduced hearing since 15 days, which was insidious in onset, gradually progressive, with no aggravating or relieving factors. There was no history of trauma. There were no other significant ear complaints, no nose or throat complaints. Past history, there were no similar complaints or any other ear problems in the past. There was no significant medication history, allergic history, personal history, or family history. On general examination, the patient is moderately built and nourished. The patient was conscious and well-oriented to time, place, and person. Vitals were all stable. There were no significant systemic findings. Coming to the ear examination, I will start with the right ear examination. Preauricular area, postauricular pinna and postauricular area appear to be normal. External auditory canal, presents with a pale pinkish solitary mass measuring about 2 into 1.5 centimeter, occluding the entire EAC. Probing could be done all around the mass except in the posterior aspect. Bleeding was noted on probing. Mass was sensitive to touch. Tympanic membrane was not visible. Tragal tenderness is positive. Mastoid tenderness negative. Facial nerve was intact and normal. Fistula test was negative. Left ear findings were all within normal limits. Tuning fork test, Rene's test was done with 256, 512, and 1024 hertz. 256 hertz was negative for the right ear, and everything else was positive in both ears. Weber's test was lateralized to the right ear, which is the affected ear. Absolute bone conduction test was same as the examiner in both ears. This showed mild conductive hearing loss. Nose, oral cavity, and oropharynx were within normal limits. Summarizing the above, a 39-year-old male presented with chief complaints of mass in the right ear and ear pain both since 15 days. On examination, a pinkish smooth surface solitary mass was noted in the right EAC, occluding the entire canal. Mild conductive hearing loss present. A provisional diagnosis of pyogenic granuloma was made. Based on the history, the following differential diagnosis could be considered: pyogenic granuloma, malignancy such as sarcoma, squamous cell carcinoma, oral polyps secondary to oticoantral disease, benign tumors. The following investigations were done: HRCT temporal bone. This is the HRCT temporal bone showing a normal external auditory canal. This is the HRCT temporal bone of our patient showing a soft tissue density lesion involving the cartilaginous part of the EAC. There's no bony involvement seen. Routine investigations, evaluation for surgery, a pre-anesthetic evaluation was done. Patient was then treated by surgical excision of the mass under local anesthesia with cauterization of the base. Specimen was then sent for histopathology. To our surprise, histopathology was conclusive with nodular fasciitis. This is the histopathology images. Under 10x magnification, we can see hypercellular and hypocellular area of spindle cells arranged in storiform pattern with myxoid matrix. This is the 40x magnification showing individual tumor cells with plump brown to oval nuclei and prominent nucleoli and some amount of typical mitotic activity. Patient presented again 7 days later with recurrence of mass, and a final diagnosis of nodular fasciitis was made. This is the recurrent mass. Revision surgery was performed and mass was excised under local anesthesia. And this time, the patient was treated with triamcinolone injection given to the base of the lesion for 3 consecutive days. And was followed by secondary suturing under local anesthesia. Postoperative recovery was uneventful. This is the intra-op image after excision of the lesion. And this is the post-op image exposing the cartilaginous part of EAC. No recurrence has been noted up to 4 weeks of post-op follow-up. Patient EAC is patent, no narrowing is seen. This is the first week of post-op follow-up, and this is the 4th week of post-op follow-up. Coming to the discussion part, nodular fasciitis is a benign fibroblastic and myofibroblastic proliferation of subcutaneous tissue, fascia, and muscle. Its incidence is very low. It commonly occurs on the forearm, chest, back, upper arm, rare in the head and neck, especially the EAC. Only about 20 cases of nodular fasciitis in EAC has been reported. In fact, this is the first case of nodular fasciitis presenting as a EAC polyp as per current data. Incidence usually occurs in 20 to 40 years old people. It is equal in both males and female. Initially, NF was considered to be a reactive lesion based on the history of trauma in about 10 to 50% of the cases. But recent studies have shown it to be a clonal proliferation of MYH9 USP6 gene, fusion gene. NF is self-limited, typically shows spontaneous regression and rarely recurs if excised. Malignant transformation is present but extremely rare. Misdiagnosis is frequent, often as sarcomas. In fact, it was first described as subcutaneous pseudosarcomatous fibromatosis by Conweiler in 1955 due to its presentation mimicking sarcomas. Local excision is usually treatment of choice in most cases, but it may not be sufficient in preventing recurrence, and it can be supplemented with intralesional triamcinolone injection, which has shown to regress the recurred lesions. Laser therapy can be considered in case of lesions occurring on the face. To conclude this, I'd like to say that even though NF is extremely rare in EAC, it should be considered as a differential diagnosis in case of any mass occurring in EAC. As this case report has shown, histopathology is key in making the correct diagnosis of nodular fasciitis, and clinicians should consider both clinical and pathological findings to prevent any inappropriate or unnecessary invasive treatment. These are my references. Thank you. Sir, it could be due to both atticoantral disease or a little less due to the tubotympanic disease also. Yes, sir. So basal cell carcinoma is usually called a rodent ulcer. So it is very infiltrative, and you can see erosion into deeper layers. There could be bone involvement seen.
That's quite rare case you selected for presentation.
Yes, sir.
Good presentation.
Thank you, sir.
Our last presenter for the day, slot number 26. Final year student, Kristu Narsinghani.
Good evening, esteemed judges. My name is Kristen Narsinghani, a final year student. It is a privilege for me to present a case in front of you from the Department of Medicine, which I personally had an opportunity to witness. Imagine a young boy hitting boundaries in the field to having difficulty in holding a fork at the dinner table within a span of 2 weeks. No, this is not a riddle. This is the reality of our case today. A young boy presents to the OPD with involuntary movements of his right hand and right leg. We can see that he's moving all his joints, shoulder joint, elbow, wrist joint. The patient was apparently all right 3 days prior to the admission, after which he started complaining of involuntary movements involving his right arm and right leg. The movements were abrupt in onset, random, non-rhythmic, purposeless, brief, and sustained jerky movements involving both the proximal and distal parts of the limb. The patient also experienced some difficulty in maintaining a posture, and he also reported that he cannot perform day-to-day tasks like buttoning and unbuttoning his shirts. The movements would, however, temporarily cease during sleep, but increase at times of stress. Patient also complained of speech difficulties with unclear articulation and occasional sluttering. There's no history of loss of consciousness, trauma, fall, no history of vomiting or headache, weakness, any bowel or bladder disturbances, or any visual disturbances. On further probing, it came to our notice that the patient had reported a case of fever that lasted for 2 days long, associated with chills and rigor, but not associated with rash. The patient, however, sought treatment at a local hospital, after which the fever resolved completely. It's not a known case of epilepsy, psychiatric or cardiac disorders, was not on any significant medications prior to the onset of symptoms, and no prior hospitalizations. The personal history was unremarkable except to the point where he reported that he used to consume alcohol since the age of 10. 90 ml of country liquor, which contains 41% of alcohol by volume, 2 to 3 bottles per day, cigarettes and marijuana, 4 to 5 smokes per day. And also, what he used to do is he used to get those whiteners which we get in stationery shops, squeeze the contents in a paper bag, and then breathe through the bag until he felt dizzy. He also did it since he was 10 years old. On taking a brief, thorough history from the patient, we were thinking in direction of 3 differential diagnoses. First, sydenine scoria due to acute traumatic fever. Second, the personal history of the patient suggests that he was a known case of alcohol, like he used to intake, which was stopped only 5 days prior to the admission. So this can be a case of drug withdrawal symptoms. Also, a patient is from Bihar, where Wilson is very prevalent. So this also can be a case of involuntary movements secondary to Wilson's disease. On general physical examination, no significant findings were found. Pallor, icterus, cyanosis, clubbing, lymphadenopathy, edema, all were absent. The nervous system examination revealed that the memory is intact, intelligence is intact, speech is however slurred, and there are no hallucinations. 3 prominent clinical findings that were found positive is Jack in the Box tongue, in which the patient cannot protrude, there is involuntary protrusion of the tongue. Second, milkmaid sign, in which there is contraction of the outstretched arms and fingers. And third, pronator sign, in which if the patient is asked to extend his arm, it will involuntarily move towards the inward direction, pronate. Cranial nerve examinations, however, were normal. Motor examination and cerebellar signs cannot be elucidated because of the involuntary movements, and the gait is ataxic. We can see here the uncoordinated swinging movements of the arms and the wide-spaced legs. To get to our potential diagnosis and to rule out every other potential etiology, some tests were performed, and here are the results. The ASO titers were raised, suggesting pseudonemscoria. 24-hour copper excretion in urine was within normal range. CT showed no anomalies. 24-hour drug metabolite test in which nothing was detected and ECG was normal. So these are the reports. As soon as the diagnosis was made, treatment modality was initiated, which contained sodium valproate 300 mg BD, carbamazepine 300 mg once daily, oxazepine 50 mg thrice daily, and methylprednisolone 20 mg once daily. There was a gradual improvement in the condition of the patient within the first 48 hours, and I would like to bring to your notice how the conditions changed on day 1, the day of admission, to day 7, the day of discharge. We can see that the involuntary movements have subsided completely and the patient is stable here. Also in the next video, we can see that the gait was ataxic on first day, that is the day of admission. And now the gait has significantly improved as compared to day 1. For discussion, pseudonemscoria is a rare neurological disorder characterized by sudden onset chorea, usually and most often affects children over the age of 5 and adolescents. In conclusion, this case of chorea reminds us to maintain a very high index of suspicion for post-streptococcal neurological complications even after a single episode of febrile episode. Thank you very much.
Nice presentation.
Thank you, sir.
Can you explain me the involuntary movements?
So the involuntary movements involved only the right arm and right leg, which were asymmetrical. They involved both the proximal and distal parts, and there was no rhythm to it. And there were jerky movements, but there was no violence involved. Like he wasn't agitating.
What is chorea? What is athetosis?
So chorea is dance-like movements, if described in a very vague terms, and athetosis is very slow movements of mainly the distal parts of the limb.
And what do you think the child presented, you had a chorea athetosis or just chorea?
So chorea.
Then why there the distal movements are there in the child?
So both proximal and distal movements are there.
When proximal and distal movements are there, we say chorea athetosis, not chorea. Chorea predominantly involves the proximal muscles.
Okay, sir.
Why did you ask history of joint pain in this case?
So we were suspecting rheumatic disease, and so we were suspecting rheumatic arthritis if he had an episode of like joint pain before.
Suppose the child has got similar movements and joint pain. What will be your differential diagnosis?
So I'll be thinking about the rheumatic part more subsequently, because then I'll also search for ECG and see if there are any cardiac involvement to see if there's rheumatic heart.
Joint pain, these involuntary movements together occurring in a child, simultaneously occurring in a child.
So I would have still thought about rheumatic disease.
No. Since rheumatic fever is a long-term manifestation of rheumatic fever, you can't have a swollen joint to dance. It doesn't happen. Since rheumatic fever is a long-term manifestation, this joint swelling will not be there.
Yes, sir.
Any child and adult has a joint swelling as well as a chorea. The differential diagnosis is SLE. SLE
Yes, sir.
can have this chorea as well as the joint movements, not a rheumatic fever.
Yes, sir.
Another thing, why did you thought of Wilson's disease in this case?
So Wilson's is very prevalent, and in Wilson's also we see that there are involuntary movements because the basal ganglia is involved. So, and it occurs in the same age group, sir, a younger age group.
In Wilson's, when do you have a hepatic manifestation, when you have neurological manifestation?
So hepatic manifestation is early as compared to neurological manifestation. For that, we did a 24-hour urine copper excretion test, but it was within normal limits.
But more than the copper excretion test, I am happy if I looked for the KF in this.
Yes, sir, the KF was absent, sir.
Have you mentioned KF in this?
Sir, I mentioned in my negative history no visual disturbances.
No, visual disturbance is different from KF ring.
Yes, sir.
KF ring is an objective finding.
Yes, sir.
Another thing, what is the triad of Sydenham chorea?
I'm sorry, sir. I have to read about it.
The triad is, you should look for the emotional lability.
Yes, sir.
You mentioned the CNS examination.
Yes, sir.
The emotional lability term should be there. They are emotionally labile. Emotionally labile and hypotonic. They are hypotonic.
Yes, sir.
And they have chorea for movements.
Yes, sir.
Hypotonia, chorea for movements, and emotional lability is a triad of Sydenham chorea.
Yes, sir.
And another differential diagnosis I can think of SSPE. Have you heard of SSPE?
Not that I remember.
Subacute sclerosing panencephalitis, because some of the movements you observed, it looks like myoclonic, flinging myoclonic movements. And this, what history will ask, suppose if you think of SSP, what past history you are going to ask in the child or adult?
Sir, if he had contact with any contaminated water, if
Then history of measles or receiving measles vaccine in the past. Okay. Why did I ask history of throat pain and fever, throat pain in this case?
So acute rheumatic fever, beta streptococci infection. For that, I wanted to ask about the fever and throat infection, pharyngitis. Sir.
Normally, you don't get such history in rheumatic chorea because it's long-term manifestation. You don't get such an history. Okay. You have mentioned about ASF titers. What were the ASF titers in this case?
So 1:8.
It's normal. If you get ASF titers 1:8, it is normal in all. What is the significant ASF titers?
So I'll read about it. Sir.
Okay.
Thank you.
Good presentation.
That was our 26th and last presenter for this competition. Congratulations to all of the participants for their exceptional presentations and insightful contributions. Your dedication and expertise have truly illuminated the future of medical practice.
We would like to invite our respected principal, Dr. Arvind Patil, sir, to say a few words, please.
Good evening to everybody. Respected faculty members, juries, most important, the participants, and my esteemed student colleagues. At the outset, as a principal, I'm overwhelmed by the presentation, the quality of presentation, the rarity of the disease covered, the depth of the knowledge you possessed in a short period of time, and the knowledge you shared with your other colleagues is very appealing to me. And now with this, I'm going to cancel 2 classes. Second and fourth Thursday, there will be no classes for undergraduates. So there will be similar activities from any extremism, similar activities. It could be talent, knowledge and skill based. It could be even literary based also. So now new timetable will come. There will be no class between second and fourth Thursday. So this has given us a good boost to improve the quality of outcome of the students. And I'm very much indebted to all of you for doing a wonderful presentation and the spectators. I cannot forget Dr. Anuja and her team, Shri, Sanvi, Jay, Ishika. In such a short period, they were after us, pushing us to get this done at the earliest. So it has begun very well. And yesterday also, we had some wonderful presentation from 22 batch, and some of the other students also, where 34 presentations were done. So it's a very tremendous response from the students. So as a result of this, all faculties, we are already started discussing how do we make our students much better than what they are today? What are the opportunities we must create for them? And similarly, I have got two, this thing. One is from Usmania and another is from Devaraj Medical College also. So only thing I have to discuss, because they overlap with some internals, they overlap with something, I will have to discuss with HODs. We will not stop sending students, but we'll see what can be done for those absent days. So that policy of the institution will make it. So that because those dates are not in our hand, those dates are reflected by somebody else, and students have to apply well in advance and they get selected. So those new challenges as a principal, I would always look with HODs to facilitate students instead of saying that how can they leave internals, how can they do like that. Let us see what mechanism can we evolve to compensate for those things. So with this, I think I would call for students feedback, few students feedback, so that the result sheets are ready. And I would be very happy that today only we would be giving the results, so that this thing. And those who have not got the prizes, I don't think you should worry. I did not see any below the benchmark, which as a student I have seen when I was a student. You are much above the benchmarks. I think Sureka will definitely agree with that. Much above the benchmark. Yesterday she missed a qualitative pathology slides, IHG slides, very amazing slide. And thank you slide also was a pathology slide only. So that was very appealing. I think you did that. So like that, so much of innovations we saw into those things. So before they finalize, I would like to thank the judges. The magnitude 2 days actively participated and done a wonderful work for the students. So I would call some of the students, even the spectators also can come, not necessarily the presenters, 1 or 2 feedbacks, so that which can help us to bring better what we have done today. So I seek some of the students coming forward, please. Arihant, I think you can come. Because you go to many conferences, you achieve so many laurels. So what is your feedback? And I don't want everything to be praising feedbacks. What can be added also is taken very sportively and very nicely also. So, Arihant.
Good evening, everyone. Good evening, judges. Good evening, sir. Actually, I have been to conferences, but I haven't seen such well-organized case presentation like this before. I have been to many international, national, and state conferences, but I agree that sir gave chance to all the presenters. Not one of them was missing. Like many abstracts were submitted, but but all were allowed to present. And I'm happy that everyone got an opportunity to present. Thank you.
I would invite one of the judges to come forward and give your feedback.
Very good evening to all. I am really envious of you because you had such a wonderful principal, sir, and other faculty members who have given a stage at this age to present your scientific paper. You are really blessed to have such a principal other faculty members and continue this temper. Don't lose this temper. You continue to present, so we'll get more. And apart from this, let's have a practical sessions as well, so that you may be presenting the hepatomegaly, splenomegaly, but should have a practical session as well. Thank you.
Any other faculty members would giving their opinion, it is most welcome so that it adds to the value of this quality presentation. Hello.
Good evening to all. Just I want to tell, I think you have presented wonderfully. I have seen all the presentation today. Yesterday I was on leave. I was not there. But today's presentation were very nice. I want to tell only, it is a suggestion that when you are preparing the slide, first slide, I think here you have not put the name of the guide or so. So when you are presenting these slides outside, whether there is a conference or anything, you have to put the college logo and the university logo and the name of the college first in the first slide. That is my sincere advice to all the students when you are presenting outside, because you are representing our university and the college. The logo has to be there. This is my sincere advice to everyone. And in most of the presentations, I have seen that few of the students, they have put the references and all. All the students at the end of their presentation and these things, the references has to be there before your thank you. So these are my suggestions, what I have observed. And whatever you have presented wonderful presentations. A big round of applause to all the students. And we need, in such cases, when the students are presenting, we need all the students to be there. Those who are not presented, they will also come next time to present the case also. So this is my sincere advice. Thank you.
Dr. Ruchi sir, we intentionally removed the guide's name because of the preoccupied. Some of them are judges, so we did not do that. And that's why we could not do it. But I'm sure the hard work, without anything, it goes to say that there was a soft promotion by the faculties. Otherwise, to rise to this occasion, it may not be possible. They have done it. Intentionally, we removed because judges and the other favoritism will come into picture. That is the idea of doing that. And now I request Dr. Manjunath sir to do the honors, announce the prizes. Before handing over to Manjunath sir, these prizes were sponsored by our pharmacist, outsourced pharmacist, Mr. Harsha. His father is quite a significant donor. So once we requested him so that every time the prizes also will be given by him, so that every session you will go with the prize. Look at you. So I thank him sincerely. So he is the one, Anil Kumar Annarao Inchal. So his father is a very significant societal person, and he has contributed many for the student welfare, for society welfare. So I thank his father, Shri Anil Kumar sir, and also the man behind Mr. Harsha. So because of that, there's quite a significant encouragement, and the prizes are also quite worth of it.
Good evening to one and all. Before announcing the winner names, let me tell that, frankly, all the presentations were good. All 26 presenters are the winners. Though I am going to announce the name of the winners, that is first, second, third, and fourth places. Let me once again tell that all the 26 presenters are the winners of today's competition, today's and yesterday's competition. And hearty congratulations from our side, jury side, to one and all the 26 presenters. Let me announce fourth prize winners It has been divided amongst two, Yelavarti Vitusha and Alankrita Srivastav. May I call upon Alankrita Srivastav and Yelavarti Vitusha to please come on the stage and receive their prizes from principal, sir.
I request all the judges to come so that you honor them.
Yes.
Since it was tied, so in the interest of students, we added another prize because it was tied. We did not want to criticize and do 1.5 marks and try to do. So that is the encouragement for students.
The third prize goes to Tanvi Prasad. Miss Tanvi Prasad. Second prize goes to Christo Narsingani. Christo Narsingani, please come on the dais. And the most awaiting prize, last prize, but it is the first prize of this competition, goes to Mr. Aditi Kumar. Aditi Kumar. A big round of applause, please, to Miss Aditi Kumar. Thank you to all.
I thank all, and I would like to call these four: Sri Arsha, Sri Shah, Ishika, Om, Sanvi, and Jai to be on the stage, please. They were the one who were very instrumental in pushing this, and we cannot forget Dr. Anuja. Please, Anuja, come. Let's give a big round of applause. Let's. Right, fine.
Just say it, no? She'll come, she'll speak then.
Fine. We'd like to say every speaker provided ample competition with the rare diagnosis and captivating presentations they brought in. So congratulations to all the 26 participants standing here. Yeah, we just standing here. Let's just stand here. We as seniors would be leaving in 6 months or 1 year, but we really hope you juniors would really continue